We will start the session in 5 minutes. Before starting the session, the delegates who have paid for today's CME but have not given their reference ID while registering, please send WhatsApp message on my number of Paytm 9833 wala of your screenshot of payment. You will have to give your reference ID to get MMC point along with payment.
Good afternoon, sir.
Good afternoon, sir. Good afternoon, everyone. I, Dr. Amol Jadhav, Cultural Secretary of Binder Medical Association and Joint Secretary of IMA Mira Binder, welcome you all. I welcome Binder Medical Association President Dr. Prabha Posa and Secretary Dr. Chirag Shah, all the panelists and delegates. I invite Binder Medical Association President Dr. Prabha Posa Madam to say a few words. Posa Madam.
Yeah. Good afternoon, everyone. I am Dr. Ratnaprabha Pisal Posa, President of Binder Medical Association. Greetings to all on behalf of Binder Medical Association. First of all, welcome to all to the BMA Annual Scientific Conclave, which is happening virtually today. We all wanted to have our annual CME and annual day program to happen with the physical presence of everyone. But the resurgence of COVID-19 virus forced us to go ahead virtually. We have topics in the annual CME from hematology, cardiology, gynecology, management of varicose veins, and medical legal aspect in today's scientific agenda. I feel very good to note that all our own colleagues from Mira Bhinder are taking lead in this year's annual CME with respective topics. Wholeheartedly appreciate the same. Once again, welcome all, and I hand over the session for scientific proceedings. Thank you.
Thank you, Madam. I welcome IMA Mira Binder President Dr. Vivdi sir. Let's start with today's session.
Thank you, sir.
For first two topics, good afternoon, sir. For first two topics, our moderators are Dr. Harsha, who is committee member of Binder Medical Association, and Dr. Sanjay Surana, who is joint treasurer of Binder Medical Association. Over to Harsha, sir.
Thank you very much, Amol sir, for the kind introduction. Very good afternoon, all of you. I feel proud to introduce to you a very eminent speaker who is going to start the proceedings of the scientific concept that we have today. Dr. Suraj Chiranya sir is a well-known hematologist and a BMT physician. After graduating from Government Medical College, Yavatmal, he went into the
your voice is not of good quality. Please check, something is wrong.
Just one moment. Am I audible now?
Dr. Harsh, you are audible, but we cannot understand what you are saying. I would request to check if there's another device nearby, your microphone or something. Or if you have a pair of headphones, please put them
Just
on.
one moment. I'm sorry.
Your voice sounds very garbled right now.
Yeah, I'm sorry about that. Is it clear now?
Yes, it's much better. Please continue. Or you can start over because we didn't understand anything.
Yes, absolutely. I feel
Thanks.
proud to introduce to you a very eminent speaker that we have today, Dr. Suraj Chiranya sir, who is a well-known name as a clinical hematologist and a marrow transplant physician. After graduating from GMC Yavatmal, he has worked at LTMGH Sion for his MD, and DM was done from Christian Medical College, Vellore. He is currently a consultant hematologist at HCG Hospital, Kolaba and Borivali. He has several publications in renowned journals to his credit, and he routinely presents papers and posters at various national and international forums. Over to you, Suraj Chiranya sir, for a very enlightening lecture that we are all looking forward to. Thank you so much.
Hello, hi Dr. Harsh. Nice to hear kind words from you. And good afternoon, everybody, all the members of BMA and the listeners of this webinar. And thanking BMA to give me an opportunity to speak on the annual CME. And thanks for attending the webinar for all the other people on busy weekend of everybody. So I will start sharing my screen. Is my screen visible to everybody?
Yes, sir.
Yes. So the topic for this CME I chose like approach to cytopenias BMT, and some fungal infection can happen during the BMT dose. So the necessity to enlighten on this topic is because everybody in our day-to-day practice, from the GP to the specialty, the most common problem happen to us is like we see cytopenia in every other patient. Either it will be like anemia, leukocytosis, leukopenia, and thrombocytopenia. One of the most common thing is thrombocytopenia. This is the most common, and everybody is fearful about that complication, especially the surgical side, because the platelet is the most important part of our blood cells. So just we'll go through a basic details so that whenever we see any cytopenia, so we should know what to do at the baseline and when to refer to a hematologist for the proper care, because 90% of the cytopenia is secondary to a systemic disorder or a specialty disorder, so can be treated by the respective person with a simple reference or simple following a guidelines. So there is no much proper hematological requirement in 90% of any cytopenias. So if we see the basically this our blood cells are composed of three parts. First is hemoglobin, second is WBC, and third is platelet. So we will go one by one. So hemoglobin is the most important cell which carries the oxygen from the heart, lung to every part of our body. So from where this hemoglobin develops? So all the cells in our body develop from the hematopoietic stem cells. So these stem cells give rise to the all three cells, precursor as well as the proper cells. So these hematopoietic stem cells give rise to the RBC after going through a developing phase. So when we see a low hemoglobin, what will be our understanding? The understanding basically is it's due to the decreased production or increased destruction. So when we see the decreased production, it may be related to the marrow problem or or nutritional causes, which are the most common in our scenario. followed by the systemic disorders like chronic diseases affecting the ability of hemoglobin to produce normally. So decreased production mostly nutritional causes, then anemia of chronic disease. Hello. Then decreased production may be due to the hematological issues like thalassemia, sickle cell anemia. Third is a marrow failure, means it's a proper hematological problem. It's one type of emergency because marrow is not producing these cells. So we have to be very careful, and we should require a prompt evaluation when when we suspect that there is a marrow failures. And then infiltrating disorders like leukemia, lymphoma, and solid malignancies like breast, prostate can infiltrate the bone marrow and cause the low hemoglobin. Then increased destruction and loss, basically blood loss is one of the commonest cause due to the any reason, maybe GI blood loss, other road traffic accidents, or bleeding from any oral cavity or any orifices. Then hemolytic anemias. Hemolytic anemia is a broad category. It has subtypes like intrinsic and extrinsic. There are various disorders associated with it. We don't go in much detail because of we have less time. So second part comes to be a WBC. So WBC also produced from the hematopoietic stem cells, and it goes through the various maturation processes to give rise to the lymphocytes, neutrophil, basophils, and eosinophils. So when we tell leukopenia, when WBC count less than 4,000 or ANC less than 1,500. So same here. So it may be due to the decreased production and increased destruction. So decreased production due to the nutritional vitamin B12, folate, marrow failure, aplastic anemia, and infiltrating disorders. And increased destruction due to the sepsis. Sometimes we are confused, like in sepsis mostly leukocytosis happen, but in condition where sepsis is severe, DIC sets in, then there is a pulling of the platelets in the lung, spleen, causing the more destruction. So the low platelet is also one of the signs of the sepsis, severe sepsis. Then we are coming for the platelet, the third part of the blood cell line. So it's also produced from the stem cells, and after going through a maturation process, we get a platelet in the circulation. So here mainly the causes like decreased platelet due to the increased consumption like sepsis, bleeding, and ITP. Decreased platelet due to the consumption is the most common causes in our day-to-day practice. Either it may be due to the dengue, malaria, and various leptospirosis that we see commonly in Mumbai. That is most common causes of the decreased platelets. And lack of production due to the aplastic anemia and megakaryocytic thrombocytopenia. So when the patient comes in our clinic, so how we'll evaluate this patient? So the most important in any case scenario, how advanced we become, the basis of any evaluation is a history taking. So what are the patient complaints? So we have three things causing have a specific function. So low hemoglobin mostly causes dyspnea, breathlessness, paleness of the body. WBC decrease causes recurrent infection, and platelet causing the bleeding manifestation. And once we have these complaints, we need to go through the ODP, like onset, duration, progression, and we should always because we have to know whether these things are the acute and chronic, and it's associated with the B symptoms like there is fever, weight loss, and the excessive sweating, mostly in the nights. And once we establish the diagnosis, no, once we taken the history, we need to ask the complaints related to a specific system.
Excuse me,
So
Suraj, sir.
yes.
I'm sorry to interrupt. We are still seeing your first slide and it is not in full screen. I think you will need to just exit the slideshow and put it on again.
Okay. Sorry. Are you able to see right now?
Sir, I can see your screen now. You just need to go in full screen mode. The slideshow is not on yet.
Now?
No, sir, we don't see the slideshow yet.
Hmm. Only first slide is visible, correct?
First slide, yes.
Now?
No, sir,
Hello?
we still, you have already switched on the slideshow, but we are still seeing your PPT screen. So, sir, even if you could zoom this, I think that would be fine.
Piyush, are you there?
Yes, sir, I am here. Actually, his
Please
video
guide,
is
sir.
getting stuck.
So
After you share the screen, just select entire desktop.
sorry, I didn't get you.
Once you click on share screen on the below button, and then you
Yeah,
just have to click on entire desktop.
that's all. Okay,
Yes.
okay, 1 second.
PowerPoint screen, sir, share the entire desktop.
Okay, okay. Entire screen, correct?
Yes,
Yes.
sir.
Yeah, sir.
Okay.
Now
you
go
can.
back to the presentation.
Okay. Now?
Yes, go full screen. There it
Yes,
is.
now we see it full screen.
Okay, now it's okay.
Yes, sir. Perfect.
So just I will rush through these already spoken slides. So we have three cell lines: hemoglobin that we get from the hematopoietic stem cells that give rise to the RBCs. Then low hemoglobin, decreased production due to the deficiencies, nutritional and anemia of chronic disease, thalassemia, sickle cell, marrow failure, and the infiltrating disorder like leukemia, lymphoma, solid tumors. Now is it visible clearly? Yeah.
Yes, sir, it is fine now.
Yeah. Decreased destruction and loss due to the blood loss and hemolytic anemias. Second is a WBC. That is due to the first means so so WBC are two types, basically lymphocytes, and the second like granular, like neutrophils, basophil, eosinophils. So when we say leukopenia less than 4,000 or ANC less than 1,500, so that is the same thing: decreased production and increased destruction. Decreased production, nutritional, folate, mallow failure syndromes, infiltrating disorders. Increased destruction due to the sepsis. So coming to the platelets, platelet also produced from the hematopoietic stem cells. So the stem cell give rise to all the three cell lines in our body. After going to maturation phases, it comes to the circulation. So platelets, most common cytopenia we see in our day-to-day practice, and it's most common cause to refer to a hematologist. So mostly it's due to the increased consumption due to any infection, sepsis, due to the bleeding and immune thrombocytopenic purpura, lack of production due to the aplastic and a megakaryocytic thrombocytopenia. So so once we see this any report like this, we have to have a detailed history regard outlining what are the symptoms related to a cell lines like dyspnea, recurrent infection, bleeding manifestation, onset, duration, progress of everybody of the symptoms to know the chronicity, means whether it is a acute or chronic and associated with any other symptoms, and there is systemic any complaints are there or not related to every organ in our body. So on clinical examination, we see is the anemia, mouth ulcer due to the leukopenia many times, ecchymosis due to low platelets, icterus, lymphadenopathy, hepatosplenomegaly. So these are the most common findings in the clinical examinations. And once you see all those things, so I rushed through all, up to this through the slides. Now I will come slowly afterwards. So after we see after we have these symptoms, so how we evaluate this? So CBC plus retic is the most common test we do for every our patients, and every practitioner does this test routinely for every of their patient. When we see a CBC, actually the report sometimes is very messy. We usually see only hemoglobin, WBC, platelets. So, but as a hematological point of view, these reports are very important, because nowadays because of the technology, all the CBC machines who calculate, they have special technology called as VCS, volume, conductivity, and scattering. So every cell in our body has a different volume, conductivity, and scattering potential. So depending on that, the counter identifies whether it comes in the normal or in abnormal size. Once it's abnormal, the machine flag, they will tell there is abnormal WBC are seen in the that CBC sample. So after getting a flag, so we have to see under the microscope what morphological problems are there with the cell lines. So this is the very critical step of evaluation any hematological disorders. We will come to the next slides to how can we easily diagnose after looking in the microscope the various disorders. So so when we see for peripheral smear examinations, because nowadays there are busy labs who runs around 1000 to 2000 samples per day, it's not feasible for them to look at every smear in day-to-day practices. So when the clinical indication for peripheral blood analysis are like when all the cell lines are affected, there are nutritional anemias are there, because vitamin B12 can be easily diagnosed on the peripheral smear. Parasites like malaria can be diagnosed, and malignancies like leukemias can easily be diagnosed on the peripheral blood smear examination. So after taking CBC, we have to evaluate with the specific tests relating to the organs, LFT, creatinine, hemolytic anemia suspicion, then direct Coombs test. And if we are suspecting some malignancy, then we need to find out the tumor lysis markers. So when we'll do the bone marrow examination, so this is the very critical point, and because most of the diseases which are skipped on the peripheral smear examination can be diagnosed on the bone marrow examination. So when we'll advise for bone marrow, when more than one cell lines are affected, when lymph nodes and organs are enlarged, there are no response to nutritional is the most common cause, but if not responding to the vitamin supplements, we should go for bone marrow. Then when there are abnormal cells in the peripheral smears and recurrent infection. So the example you see, sometimes the normal smear looks like this. The pink color cells are the RBC, the violet color small cells are the platelets, and the big cells are like neutrophil, the WBC in the smear. So RBC abnormalities, if you see the pink cells in the above smears, there are some above is the microcytosis, and down is the some target cells with the hollow center. So these are the commonly sees in various disorders. The above is the megaloblastic anemia, and sometimes these downwards can seen in the iron deficiency like pictures. So and some thalassemia disorders, if you see the pink color cells, there are the dot in the center, these are called the target cells. So this can give a suspicion of thalassemias, so that we can proceed to the further test for evaluation. This is regarding the RBC. For WBC abnormalities, if you see the neutrophil with multiple lobes can be seen in the megaloblastic anemia. These are called as hypersegmented neutrophils. Then there are abnormal RBCs like we see in this, like a very big cells with the abnormal morphology. This can be seen in the various leukemias. Can be easily diagnosed on the blood smear examination. And coming to a platelet, most common thing, if you see there are some dots in the slides. These are the dust like particles. These are the platelets. So most common cause of the thrombocytopenia is a pseudo-thrombocytopenia. If you see the clumps of these dust like particles, this is called as aggregation, happening sometimes due to the EDTA present in the CBC tube that gives rise to the clumping. So whenever you see a low platelet, first ask for the peripheral smear examination, and the peripheral smear shows this clumping. So there is a definitely pseudo thrombocytopenia. There is no at all bleeding risk associated with it. Once we see this, I will have one case discussion here. A 20-year-old male present with a pallor and dyspnea, and he also complains there are little bleeding, and he had mild infection every time. So once we investigate, we see the smear on the left. If you see there are no cells, where are randomly very scanty cells, we proceed with the bone marrow, there is a dry tap. So the diagnosis seems like aplastic anemia where all the cell lines like hemoglobin, WBC, platelets are decreased. So it's a diagnosis can be made easily after doing the bone marrow test. So the bone marrow, the aplastic anemia, most common and curative approach is a bone marrow transplantation. That is helpful in 80 to 90% of all the patients. Immunosuppressive treatment like ATG in 40% and androgen therapy in the 10%. So what is a BMT? So we'll get through the basic steps of the BMT, and I have one video also of 3 minutes. We'll see at the end of this. So steps of BMT. BMT basically of two types: autologous and allogenic. In autologous, patient himself is a donor. In allogenic, one HLA related matched donor is available, which can be in the family member or outside the family. So once we have donor, the basic step is having a donor for any transplant. Then we need to prepare a patient for BMT. Hello. So then we need to prepare a patient for BMT, and how to prepare? We need to control the cancers and other complications before BMT. Pre-transplant workup we need to do for patient and donor to see whether they are fit and eligible for the transplant. Once these all three steps are done, then we need to start the conditioning regimen to the patient. So what is conditioning regimen? It kills the bone marrow cells of the deceased patient, and after killing those cells, we'll give a normal hematopoietic stem cells that we collect from the autologous or the allogenic donor to the patient. And the transplant process is not a big one. It's a simple blood transfusion. Once we collect the stem cells, we have to just transfuse like a blood. There is no major surgery for it. And for the donor, it's a 0% risk. We don't take means it's a safest of the transplant. There are no data like any donor died during any collection till now. So these stem cells go to the blood, and they found their space in the bone marrow in the body. So till these stem cells start to function, they start to produce hemoglobin, WBC, platelet, we need to support. The most common complication is the infection. That is sometimes very dreadful if the organisms means blood culture shows a persistent organism growth. This is only most common cause of mortality and morbidity in the BMT process. And once new bone marrow start functioning in 2 to 3 weeks, then all the infections and all platelets will come up, so all the complications will start to disappear. So the types of BMT, as I told, there are two types: allogenic and autologous. So in autologous, the patient himself is a donor, so that's why autologous. In allogenic, somebody else will donate. So most common is like a family member, brother, sister. If these are the most common in the family who matches with the patient, and then the parents. So these are related donor transplant. So it can be fully matched, or sometimes if there is no matched sibling, we need to do the half match stem cell transplant. And some are like fully HLA match unrelated donor registry are there. Like blood bank, we have HLA registries where they do the baseline screening for the donors, and once the suitable donor is there available, then we start contacting that donor. So this is also a procedure. So in India, there are also BKMS, DKM means BMST organization is there, Datri organization is there, who maintain such registries, and internationally there is DKMS from Germany, NMDP from US are there. So these are all voluntary donor related transplant. So first step was a donor
2 minutes for the session. Thank you, sir.
Hello.
So we have 2 minutes left for the session.
Yes, I am rushing through. So second is a collection of the stem cells from the patient. First, stem cell can be collected from the bone marrow. Like previously we used to collect from the hip bones. Now we have these machines, so that we give injections to a donor and we collect the stem cells from the donor. So if you see the downward, there is a bag. This is stem collection bag. It's like a routine blood. If you see, it's like a platelet bag. If you see, but the different color, reddish color is there. So this is a stem cell bag, and we directly transfuse. So we gone through these 5 steps: conditioning, stem cell infusion, neutropenic phase, the functioning phase is engraftment, then post engraftment period. So we have gone through all these things. So just coming to a most important neutropenic phase, after stem cell given, in this phase the patient is mostly susceptible to the infection. We have to take a high care with the empirical antibiotics and the supportive care with the blood and platelet transfusion. And once the engraftment starts, all the complications are there. Infections start to resolve, mucositis means mouth ulcers, they start to resolve. So after this phase, the most common complication is managing the donor and the recipient stem cell cells reactions. And after this engraftment, last is a post engraftment, where the patient born with a new immunity, we need to vaccinate it, because the stem cells start to produce, they are not knowing the recipient's body, so we give the vaccination in the post engraftment phase. So this is the basis of most of the hematological disorders, and just giving an insight of the high-end transplant, so that everybody should be aware. Now it's quite affordable, and it can cure the disease in almost 80 to 90% of the diseases, where previously it was like a major killer of the patient. Thank you everybody for patiently listening to the topic.
Thank you, Dr. Suresh, for your excellent and very informative talk. Thank you, SCG Borili well for the support. Now, our next speaker is Dr. Nilesh Kumar Mishra. He is leading consultant and cosmetic plastic surgeon. He did his educational qualification MBBS from Allahabad University, India, 1999, and MS General Surgery, Calcutta University, 2004, MRCS Royal College of Surgeons of England, UK, 2006, NCH Mumbai University Plastic Surgery, India, 2008, Fellowship in Microsurgery and Reconstructive Plastic Surgery from Spain from January to April 2016. He had many memberships of associations like Indian Association of Plastic Surgery, Indian Association of Aesthetic Plastic Surgeon, Venus Association of India, American Association of India, American Academy of Aesthetic Medicine, member of Association of Hair Restoration Surgeons India, Association of Surgeons of India. He performed many cosmetic procedures successfully like breast reshaping and reconstruction, abdominoplasty, liposuction, hair transplant, rhinoplasty, nose job, facelift, Botox filters, and fat grafting, dimple creation and lip reshaping, and other cosmetic procedures. Many reconstruction and trauma surgeries like reimplantation hand and digits in industrial trauma, flap surgeries and perforator faced flap, microvascular surgeries, cleft lip and palate, ear reconstruction, hypospadias, and many more. He had many achievements, successfully operated multiple hand replantation surgery, news published in various newspapers, and he had performed many workshops. Also, two of them are like cosmetic and reconstructive surgery in LPMC Sion Hospital, Mumbai, flap dissection course, accredited speaker of IMA Maharashtra, taken various CMEs on plastic surgery and liposuction, attended certification course in vascular USG and minimal invasive treatment of venous disease, workshop in hair restoration, FUE and FUT, and furthermore, so many things about him to say. But now here it will be now over to Mithilesh Kumar Mishra for lecture.
Sir, kindly unmute yourself. Mithilesh sir, kindly unmute yourself. Kindly unmute yourself. You are on mute.
So I am on mute. Okay.
Yes, sir. Yeah, thank
you. Is it now?
Yes, sir. We can hear you. Continue.
Okay. This is Dr. Mithilesh Kumar Mishra, and thanks Amol and the Mira Bhainder Medical Association to introduce me and giving me this opportunity to present the varicose vein, one of the very common but commonly undiagnosed and undetected things. There is little hiccup. Amol, my slide is open. Hello.
Piyush, can you please help?
Yes, sir.
Mithilesh sir, Piyush will help you.
Okay, Piyush.
Yes, sir.
I'm just trying to open through the, what is the meeting ID they are saying?
There's no, there is a link that is shared, sir, actually. They just have to click on the link and it will open up for everybody.
Am I?
So I would suggest that you don't use two machines at the two devices at the same time.
Okay, just.
Your voice is going to go off. I'm going to mute you. Okay. Dr. Mithilesh? Please unmute yourself. I would like to mention that I would recommend that you don't use two devices at the same time because it is going to cause a lot of audio problems. I can see that many people have joined with two devices at the same time.
Okay. Just hold on. Just hold on.
Yeah, I can hear you, sir.
Just hold on. Just give me 1 minute. We'll try to.
Sure, sir.
Okay. Am I audible?
Yes, sir.
Okay, one device I have already muted. Am I visible right now?
We can't see you, but we can hear you.
Okay, you can't see me, we can't hear you. Okay, why am not?
Switch on your video.
Okay, I have switch on my video.
Yes, we can see you.
And my voice is coming.
Yes, sir.
And my PPT?
No, not the screen.
Okay. Now?
Yes, we can see it now.
Is it?
Yes.
Okay, sorry for little income. I'm not very used to and savvy with all these gadgets and all those things. This is Dr.
No worries, sir.
Mitra.
Sorry to interrupt, sir. Piyush, can you guide them to enlarge their PPT full screen for full screen view?
It is in full screen itself, sir, right now.
Okay. Thank you.
Okay, shall I go ahead with?
Yes, sir.
So, thanks for such kind word and just hooking up with me for the sake of gadgets related to Zoom and all those webinars. So I'm going to discuss something related to varicose vein. Hello.
Yes, sir. Please go ahead.
So varicose vein is one of the very common disorder, but commonly undiagnosed and undetected. So today I'm just trying to be as compact as possible, and at the same time we'll try to give a basic idea about varicose vein, what is the magnitude of the problems, how we are going to diagnose it, then what are the different modalities of treatment, and then which one is the best among all the treatment options available to us. So first of all, what is the magnitude of the problems? So if this is just about one patient who is known to me, he came to me after around 15 to 16 operations related to varicose vein, if you see all these things. And finally, he landed up to us with bleeding, ulcerations, and he is little obese patients having lots of problems. So finally, we have to do his saphenofemoral junction ligation along with again the perforator ligation, because already laser and all those ablation was done beforehand. So I am trying to mean is what exactly is varicose vein, why it is so difficult to treat it, or is it so difficult to treat it? So let's start our discussion by simply what exactly is varicose vein. So if you see the varicose vein, you can make it out that this is basically the elongated tortuous and nodular vein that you can make it out by seeing from a distance. But as a plastic surgeon or as a vascular surgeon, if you see, we are having basically three different variations of the diagnosis and the definition of the varicose vein. One among that is what exactly is the clinical one, where you can see and make out the dilated, elongated, tortuous vein. But the most important is this anatomical, that is the reversal of blood flow. This is very important. And what is the meaning of this reversal of blood flow? If you see in any parts of the living body tissue, there is two ways of blood flow. One that brings blood in the form of arteries. Then after the use, it has to come back via the vein. And for all practical purpose, veins of the leg and hand, they have to go towards the heart. That means they have to move, they have to travel against the gravity. How this happens, that is very important. And if it is going up, why not it is coming back? That is because of the presence of this valve. If you are able to make it out, there are valves within the vein. They allows blood to flow from down to up. That means only in one direction or unidirectional blood flow. While in arteries, it flows in both the directions. But in vein, because of the presence of the valve, you can make it out in these figures. Because of the presence of the valves, the blood flows only in one direction, that is from down to up. What happens if this blood flows in both the directions? The moment any person stands, because of the gravity, blood will pool within the blood veins, and then there will be dilatation of the vein. This is what exactly happens whenever there is a valvular damage or valve damage. Then there is a reversal of the blood flow from deep to superficial, leading engorgement and elongated superficial venous systems. I will come little later about that in more details in anatomy. There is one other definition, that is the physiological. What is that? From the deep vein system, blood flows because of the incompetency of the valve from deep to superficial. Then via superficial, again it has to re-enter. Mark my word, it has to re-enter again into the deep system. So this is the cycle. This is a closed cycle. From deep to superficial, from superficial to deep. So more or less, this is very common. This reflux is present at the saphenofemoral junction, sometimes at the saphenopoppliteal, from where deep vein ejected or reflux the blood into the superficial vein, and then it has to re-enter through the perforators. So this is the photographs. You can see the valve, and once valve is damaged, then abnormal blood flow leads to dilatation of the vein, and then ischal bulging and thin valve of the vein happens. And you can see in these photographs again, once there is a normal valve, blood flows from down to up. But the moment it starts flowing from up to down, it closes, valve closes. This is the normal. On left-hand side, these the first two figures. But on the right side, if you see, the blood is flowing in both the directions. One is going up, other one is bringing it down. That is the damaged vein or the varicose vein. What happened? Because of any reason, if valvular damage is there, then there will be chronic venous insufficiency. That may be because of primary, where no cause is unknown, or maybe secondaries because of trauma, or sometimes deep vein thrombosis, or sometimes infection, some interventions in the vein, or sometimes there is a congenital defect in the valve that leads to dilated veins and venous wall dysfunctions, then chronic venous insufficiency, and all the problems related to the varicose vein or venous insufficiency in the form of dilated veins or varicose vein and dermatosclerosis, edema, ulcerations, bleeding, and all those things. If you see, these are the certain photographs. You can make it out. There is a valvular nodular vein, then there is telangiectatic vein, then there is edema, discoloration, ulceration, even sometimes bleeding. These are the different stages of the vein, varicose vein, I mean. Usually there are 6 different stages, what we call as clinical. If you see the anatomy properly, then you can make it out. There are 3 systems, 3 venous systems present in the leg. One that is just under the skin, which we call as superficial venous system. One which is deep venous system, which presents within the muscles, and then in between the connecting system, which we call it perforators. If you see, you can make it out the superficial venous system, then the deep venous system, and then the perforators and the tributaries. How this venous flow returns against the gravity. Normally, blood or liquid flows from up to down and from high pressure to low pressure. But how this from low pressure to high pressure and from down to up, it flows back. That is little bit complex things. I don't want to make it too complicated. One thing, there is a presence of muscle pump in the foot, in the leg, in the thighs. Most important, this leg calf pump, what we call it. But because of the arches of longitudinal and transverse arches of the foot, then there are muscles in the thighs, and presence of wall make it possible for blood to flow from down to up. And because of the presence of the wall that allows only one directional flow, it won't come back. But what happens if there is damage in the wall? Then all these will filled up with the blood. Then it engorged, make it more nodular, morphologically elongated, tortuous, and to accommodate more blood and more blood, there is a multiple tortuosity and all those things found. That is what is basically the pathophysiology of the varicose vein. So this is the perforator I was talking about. You see the valves just under the skin, the superficial venous system, within the muscle, deep vein system, and the connecting one, that is the perforator. This I was talking about the reflux phenomena, re-entry phenomena. If you see the femoral vein, through that blood is flowing back within the long saphenous system or great saphenous vein. Then through that it re-enters again into the deep system. This is what this pathway, this is reflux and re-entry phenomena. This is one of the very important things, especially when you are doing color Doppler to diagnose it. I will comment little later. But when you are coming and doing the sonography, this is the most important diagnostic tool. The person who is doing must know this reflux, re-entry phenomena, and then the caliber and the dilatation of the veins. Again, the same thing, re-entry. So this is just about what exactly is varicose vein, what is normal anatomy of the vein, how this varicose vein, it happens and how it presents. But what are the etiological factors? It is said that it is more common in female, especially because of the pregnancy and the hormonal issues. Then around 10 to 15% of men and mostly the older women are having all these problems. The other risk factor is obesity, then secondary lifestyle changes, so is prolonged long standing and pregnancy. These are the few photographs. You can see the air hostess, they have to stand for long hours, or the traffic inspectors, or the army men, and these people are more prone to develop varicose vein. The old age, obesities, and then obviously the family history is also one of the very, very important parameters. How it manifests itself. You can see only the spider vein, little thin veins around just under the skin. You can visually see them, or sometimes enlarged vein. You can make it out. Then sometimes patient may present with mild swelling of the ankles and feet. Sometimes it is painful, sometimes heavy legs, sometimes they are not able to explain except they say, sir, I'm tired, or sometimes it may have the crampy pain or throbbing pain, then itching because of the skin changes. What happens whenever there is excessive pressure within the vein, then there is micro leaks of the blood from the venules just under the skin. Then over sometimes this water portion of the blood get absorbed and the protein and all those iron and other minerals just get deposited just under the skin, leading thickness of the skin, discoloration of the skin, and a reactionary induration of the skin. That leads to itchiness of the skin, and if you itch it, then there will be formation of wound. And if underneath venules are there, which is having high pressure because of hypertension, venous hypertension, then there might be bleeding. This is one of the very important classification to diagnose and stage the disease. That is known as the clinical CEAP, or clinical etiological, anatomical, and physiological, pathological, for just to reporting standards in different places of the world. This is how it is. The clinical C0, C1, C2, C3, 4, 5, 6, from no visible to telangiectatic vein or spider veins to varicose vein per se, or edema, skin changes, then ulceration, or sometimes active ulcer or bleeding. That is the stage 1 to 6. This is one of the very common clinical classification. Then there is a etiological, whether primary, congenital, or secondaries, or sometimes no cause is identified. Similarly, it involves only superficial vein, or deep vein, or perforator, or we cannot find out any reason. Same is true with the pathophysiology, whether reflux is there, obstruction is there, or both is there, or none is there. According to the clinical, then this is how it presents, from no visible veins to telangiectatic spider veins or reticular veins to nodular veins, then edema, skin discoloration, then sometimes healed ulcerations or active venous ulcers. How we diagnose it? Mostly it's a clinical. But believe me, many a times patient may present very vague. So your clinical acumen and your
Sir, we can't hear you.
I think we lost internet. This video is also frozen.
Yeah. We'll just wait for 1 minute.
Yeah.
Yeah, he's back. Sir, unmute yourself.
Dr. Vitra, please unmute.
Sir, you are on mute. Kindly unmute yourself. We can't hear you, sir.
right now,
Yeah.
Yes, sir.
am I visible?
Yes.
Okay. So clinical
We
is,
can't see your PPT actually, sir.
pardon?
We can't see your PPT presentation.
But hold on. But am I visible right now, Amol?
Yes, we can see you, sir.
And my PPT?
Not yet.
Why it happens? I don't know why it is. I'm not visible.
Piyush?
Yes, sir. Are you sharing and clicking on desktop?
Huh?
After sharing the screen,
Screen, so I have already shared, but I'm not able to see right now the screen sharing. Then again, I have to, I think, go to the Zoom.
yes,
But
you
share
can
screen
share.
option is not coming.
Or do you see a small bar on the top or bottom that says that your screen sharing? Can you see a small bar on the top of or bottom of the screen?
No, Amol, I'm not able to see it. Am I right now?
No, sir.
Share screen. Now?
No, sir, not yet. Yeah, it's coming.
Now?
Yes,
It's
I can see
coming?
your screen now. Yes.
Okay. Sorry. Again. So the most important thing is the clinical, and your clinical sense that this wound is or because of varicose vein. Once you are having this very, you can say, sense that if a wound is there, if something is not healing, then it may be because of varicose vein. If you are not expert in varicose, then only you can diagnose a varicose vein. What I feel and what I practice, that if any person is having a wound which is not healing, Or if somebody is having swelling or discoloration and which has been treated for eczema or any other skin pathology, but not getting relief, why not to have this thinking that this might be because of varicose? Like any wound should heal by itself. That won't require anything else except the nature's help. But if a wound is not healing for more than months or years or weeks, why not to think why it is not healing? Once you start thinking why it is not healing, then only you will be able to think that this might be because of varicose vein. And then the role of color Doppler. And color Doppler role is the most important factors to confirm your diagnosis. Many a times, I'm not naming anybody, but if somebody give a reports related to color Doppler that varicosity is noted at blah 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 position, it is of no use unless and until you mention what exactly is the status of saphenofemoral junction, whether that is competent, that is incompetent, whether that is incompetent in systolic phase of vein or in diastolic phase of vein. Then what is the diameter of long saphenous vein and small saphenous vein, whether there is any accessory vein, long saphenous vein present or not, anterior accessory or posterior accessory, whether they are competent or incompetent, what is the diameter. Then the perforator, same thing is with the perforator, whether they are competent in the systolic phase or in diastolic phase of the perforators. What is the exact diameter and the location of the perforators? What is the status of deep vein? If deep vein is not patent, in say for example, it is because of deep vein thrombosis or some fibrosis or anything like that, then you cannot do anything for the long saphenous vein, I mean superficial vein. So one passage you have to be clear that deep vein is clear, then only you can do anything related to superficial vein. Usually, for my practical experience, it takes around 40 to 45 minutes to finish the color Doppler. If anybody is doing in less than that time, in 5 minutes, 10 minutes time, then believe me, he or she is missing something very, very important. And then if he is missing, as a surgeon, you are missing, as a clinician, you are missing with the information that is of no information, varicosity is noted. But what is the cause? Where you require anything to do in this case or not? So this is one of the very, very important things. I always discuss this with my radiologist. Look, I'm suspecting varicose vein in this patient. Kindly do it in a standing position and mention it, mark it. If there is any incompetency at the perforator level at deep saphenofemoral junction or saphenopopliteal junction, what is the diameter of the vessels, and all those things you must mark. Any abnormalities, sometimes there is duplication of the long saphenous vein, mark it. Sometimes there is a hypoplastic segments of the long saphenous vein where you cannot just do laser, you cannot pass it, mark it. Then only your diagnosis is complete. Now coming back to the most important things, how you are going to treat it and what are the goals for the treatment. Then the goals for the treatment of the varicose vein is patient should be disease free. Ideally, there should not be any recurrence, no ulceration, no reversal of secondary changes or anything like that. Halt of the disease progression and good quality of life after the surgeries with no unsightly appearance. But are we able to achieve all these goals? No. But I will come and discuss all those things little later. Let's start how we are going to treat it. So basically, you can classify the different models of treatments in 3 different forms. One that is thermal, other one is surgical, and last one is the chemical. In the surgical, We all know that venous stripping was done. That is still gold standard at many of the places, especially where sonography facility is not there during the operation. At the remote places, or if somebody is not having training how to do laser and use the laser for varicose vein immediately, then surgical, this venous stripping, ligation of saphenophyseal junctions along with activities, and just strip the vein up to the below knee is one of the treatment. And still it is being done at multiple places. But what is the problem with this side? Our side effects of the venous stripping a classical Trendelenburg operation. First of all, you have to strip the vein, you have to cut it. That means there will be pain, there may be bleeding, sometimes swelling, scarring, sometimes deep vein thrombosis, infection, sometimes saphenous nerve being damaged while stripping the vein. But most importantly, the recurrence rate is very, very high. If you see the different statistics from different books, it ranges from 20% up to 80%. Multiple causes are there. One of the causes where you remove the vein, that particular space will be filled with the venous blood, and sometimes that invites a new vein formation. That is one of the reasons. And if you are going for the thermal, then there is EVLT, that is the endovenous laser thermal ablation, and radio frequency ablation. All those MOCA, foam therapy, we will discuss it after sometimes. The thermal ablation, radio frequency ablation, and endovenous laser ablations, both is basically using the thermal energies. Laser, it works through the pigment and radio frequency. The only difference between the two is, without going into the technical nuances of radio frequency and endovenous, in laser frequency, the wire usually burn 5 centimeters of the vein in one go, while in laser, it has only 1 centimeter. So radio frequency, it is faster. You can finish both the leg in 15-20 minutes, hardly 30 minutes. While laser, it takes more time. One leg, minimum 20-25 minutes. Both the leg means around 40-45 minutes. The other difference is, with the radio frequency ablation, the recurrence is little bit more, while with the laser, it is little less.
Dr. Mithilesh, sir, just
Yes,
2
sir?
minutes more, sir.
Okay, so this is basically the laser and radio frequency ablations. Both are more or less, both are the same. I'm not going to discuss all these details and technical advances. This is the laser machine basically, where you have to fix the joules and the watts and all those things. This is how you have to infiltrate along the long saphenous vein. You see, this is how the within the vein, the laser or radio frequency is there. This is how we penetrate the puncture site. The division anesthesia, ultrasonography is important. 2 types of laser. One is 30-degree angulation, other one is 360-degree angulations. I'm not going to discuss all these details. These are the technical details, how it looks like. What are the possible complications related to laser? Sometimes bruising or DVT and pulmonary embolism can happen. Sometimes there is infection at the puncture sites, but overall it is quite safe. The advantage of laser is patient can go back to home the same days, less pain, early rehabilitation. Within 7 to 10 days, he can join his duty and everything. But again, it is operator dependent and it requires sonography. That means if somebody is not well versed with the laser, then chances of recurrence is very high. And if you go ahead with the wordings of the patients, then they say around 40%, 50%. At my centers where I'm operating routinely this varicose vein, I'm getting around 30% of total my cases in a month have been already done either laser or open techniques. That means around 30 to 40% recurrence I'm seeing at my place. Again, I'm not going to for the technical nuances of these things. Foam is basically the sclerogen that aqueous or this sclerogen agents that has to mix with the air and normal saline or sometimes dextrose water, 25%. You just inject within the small venules and the telangiectatic venous spider veins. And that is one of the very good therapy and adjuvant therapy just around the ulcers. If you inject it, then ulcer heals faster. This is how it is done. Again, it has to be done on ultrasonography. MOCA is one of the very recent treatment where it's basically chemical ablation, where you just insert, you can say, wire, which has tip is closed, and the moment you pull the plunger, it open it like that and damage the endothelium from within, and then you inject the foam therapy or chemical, so it will fibrose the whole of the vein. This is one of the very recent treatments, not very commonly done, and I am not doing right now this, but I am doing quite regularly the laser. So these are the pros and cons of the MOCA therapy or mechanical-chemical ablation. It is less expensive than the laser, but long-term effect of this is still under study. This is how the recurrence is according to different studies. From if you are doing only laser, around 10 to 15%, sometimes 20% chance of recurrence is there. But again, as I am saying, just doing laser is of no use unless until you know the perfect anatomy and the reason in that particular cases. So these are the different causes of the recurrence of varicose vein. If you just see the different reasons of the recurrence, then you can see the inadequate procedure or wrong technique. Suppose a patient is having very large diameter of the varicose vein, more than 2 centimeter, 15 millimeter, and then you are using a small amount or low amount of energy with the laser, then chance of recurrence is more. Then sometimes recanalization of the veins, and sometimes you just ligate the accessory veins and leaving the main vein. Then sometimes progression of the disease that you cannot halt it. So all these are the different reasons of recurrence. Then sonography, as I told you, is the most important investigation. Can you prevent it? I don't think so. You can prevent it. You can reduce the chances of recurrence by using appropriate technique, appropriate methods, and ask patient to use healthy lifestyles. And you must do the mapping of the vein before doing another thing. One important thing is how I do is, so I particularly prefer always to do mapping by myself. Where are the veins, how much veins are nodal, and all those things. Then after the mapping, see this, then you just mark the perforators. And I particularly prefer to combine, that is the integrated technique, where I like to operate. Being a surgeon, I like to ligate the saphenofemoral junction or saphenopoppliteal junctions, and then do the laser after having a tubation and all those things. So when I started doing since last 5 or 6 years, so then the chance of recurrence in my patients is less than or around 5%. Still, I have already done this integrated technique in 200 to 230, 34 patients only. So still a long way to go to have the substantial, you can say, data-based evidence that this is the best technique, only laser is the best. Let's see how it is. But I prefer to do saphenofemoral junction ligation, then EVLT, and if requires, then foam therapy at the same time, followed by the compression garments and diaphragm tablets. That is how I do. These are the few patients where the perforator has been marked. This is how, if required, we ligate the perforator. These are the few patients just before the operation and after the surgery. You can see the wound is healed and everything. There is no swelling, no edema. This is how just after the operation, around 3 months after the operation, you can see the tortuosity and everything is gone. The other patients came with all the edema, infections, all the signs of inflammation with the swelling and everything. So this is where we have done the saphenofemoral junction ligation at the ankle. Then we have to penetrate and go for the laser ablation. I since last almost 5-6 years I am doing this integrated technique, and with quite happy with my results, and my patient is more happy than me. The other patients, see when she came, when we did, and how it is afterwards. So again, other patients. something is wrong. Other patients. These are the few other patients having so much bad wounds. Once we did our varicose vein operation, wound started healing, and then finally patient's wound healed and he's doing well. The other patients see the pre-op photographs having the ulcers and all those things, and this is the just post-op. The other patients, if you see in these photographs, then in such situations, foam therapy is also given at the same time. Other patients, you can see these communicating veins between the long saphenous vein and the short saphenous vein. So you have to inject foam into this, and all this just obliterate in few weeks to month time. So what exactly we can go ahead with? This is definitely one of the very good technique to combine all these things, because the advantage of laser is it is almost less painful. Daycare procedures, you patient can recover fast. Chances of recurrence is less. Early rehabilitation, and if you are having a dedicated team, then result is fantastic. This is Dr. Gemini and Dr. Thomas Lick, with whom I have worked in Spain, Madrid. I have learned a lot from them. I always owe a lot. With these guys, I have learned a lot of this. Lots of respect for them. Thank you. I tried to combine lots of things. Any queries or anything like that, you can please. Thanks. Dr. Amol.
Thank you very much, Dr. Mithil, sir.
Thank you, Amol.
Dr. Mithilesh Mishra, thank you very much for your presentation. There are a couple of questions, so you could probably reply to them on the message so that they are well answered. I would like to thank you, the Bhinder Medical Committee, for giving your time for this beautiful presentation. I would now like to hand over to Dr. Jadhav sir again for the rest of the proceedings with the scientific session. Thank you.
Thank you, Harsh. Mithilesh sir, be there for 1 minute. There is one question
Yes, I'm
in the
there.
chat box actually. What if patient comes with AD or eczema on legs along with varicose veins? What will be your line of treatment for it, sir? You still prefer to use RF with such skin conditions?
See, Amol, if there is eczema or anything like that, along with the varicose vein. So if there is two problems like varicose vein and then the other skin disease, definitely I would prefer to go ahead with this varicose vein operation. At least you can reduce the severity of the problem and you can improve the quality of the life of the patients. As such, with eczema, there is no problem. I have not seen any problems related to infection because eczema is not an infectious disease. So there is no problem in doing varicose surgeries in those patients.
Thank you, sir.
I prefer laser, not the RF, because RF is having more chances of recurrence than the laser.
Okay. Thank you, sir. Our moderators for next two sessions will be Dr. Meenakshi, who is Joint Secretary of Binder Medical Association, and Dr. Uday Kumar Gachi, who is a committee member of Binder Medical Association. Over to Dr. Meenakshi.
Hello. I, Dr. Meenakshi Sheth, would like to introduce our next speaker, very famous Dr. Navneet Desai, gynecologist. She is working as a director at Shobna Maternity, director at Joanna Mother and Child Care Hospital. She is a vice president at IMM Mira Bhinder, and she is immediate past president of Bhinder Medical Association and managing committee member of AFG. Over to you, Navneet ma'am.
Thank you, Meenakshi, for those kind words. Out in here?
Yes, ma'am.
Okay, good. I'll just share my screen. So, good afternoon, everyone.
Good afternoon, ma'am.
Post lunch session is very difficult to.
Navneet ma'am.
हाँ बोलो.
We can't hear you properly. Can you increase the voice?
Now it's clear.
It's not clear.
Okay, just a minute.
Can you keep your mic close?
Now? Now you can hear me?
Ma'am, is it possible for you to use this without mic and headset?
Okay, then I'll have to use my mobile. Just a minute. I'll do that. You can hear me now?
Yes, this is much better, ma'am.
Okay, so I'll share from my computer and I'll use this.
Sure.
Right. So, my topic today is recurrent pregnancy loss, role of dydrogesterone. Coming to what is recurrent miscarriages. Now, there is a lot of confusion in the definition of recurrent miscarriages because both the societies, that is in London, that is UK, and in USA, both use different definitions. So the two definitions which are there are for the UK people, they say if it is 3 or more consecutive pregnancy losses, they claim it as recurrent miscarriages. And in USA, they are only after second miscarriage, that is 2 or more consecutive pregnancy losses or failed pregnancies, is considered as a recurrent miscarriage. Now, why we are talking about recurrent miscarriages? Because of the global prevailing condition. It is highly prevalent in 12 to 15% of all pregnancies. I don't know why this is coming here. Okay. 1 to 5% of infertile couples experience recurrent pregnancy losses, and 70% of females fail to report this. 20% are clinically undiagnosed. 50% of high risk of having another abortion after 3 consecutive abortions. Can you help me remove this? I don't know why it is coming here.
Piyush? Can you help Piyush?
Yes, sir.
This window is coming here. I don't know why.
You can just click and drag it away from this place, ma'am.
Okay. And this one also?
Yes, that one.
I cannot drag it. Yeah, okay. So now it's better. Right. Recurrent pregnancy losses, the main factors or the main causes are divided into 4 main categories. One are the uterine factors, that is abnormalities in the uterine anatomy. Then there are the Apla syndrome or the thrombophilias, then genetic and environmental factors, and most important are the endocrinal abnormalities. Recommended investigations for RPL are the antiphospholipid antibody testing, the karyotyping, anatomical defects are ruled out on sonography and other scans, and thrombophilias to be tested. Treatment options, it is based upon the etiology. Suppose the uterine factor is the problem, that is there are anatomical defects like there is a septum or there is a fibroid or there are polyps, so then we have to deal with them accordingly. If it is antiphospholipid syndrome, then we have to deal with heparin and aspirin. Endocrinal abnormalities call in for a treatment of the endocrine abnormality detected. Genetic factors again need genetic counseling. Psychological factors need treatment accordingly. The problem occurs with this unexplained factors. This is the most important problem which occurs with RPL because approximately 50% of the etiology, in 50% of cases, etiology is not known and it is unexplained pregnancy loss. So the clinical challenges are that you cannot estimate the true incidence of RPL. Most RPLs occur either before being clinically recognized or sometimes even in the first MIS period. Then again, there is one problem that the definition of RPL differs internationally. Unexplained etiology is more than 50% of women with RPL, even after comprehensive workup. That is, even after working up everything, still there are 50% of females in which you cannot determine the etiology. Again, there are diagnostic and management challenges of RPL. That is, whether to initiate a full workup after 2 to 3 miscarriages is often debated. Also, the class of patients we cater, they are not that affording. They can afford the whole workup. An exact definition of whole workup is not given, and there are different guidelines in management and approach. So, most important is dealing with the unexplained factors. Now, progesterone. So what is progesterone? Progesterone, it is progestation. That is a pregnancy, that is a hormone for pregnancy. How it works? It regulates cellular immunity. It mediates uterine blood flow, uterine endothelial adaptation to pregnancy. And drop in progesterone is possibly one step that facilitates onset of labor. Again, with progesterone, a few years back, there was a trend of measuring the plasma progesterone levels. But over time, it has seen that the plasma progesterone level may not indicate the progesterone present in the endometrium. And at times, the endometrium is deficient. The receptors are deficient. And that is why they don't correspond. Lee et al. In 2002 showed that endometrium of Dr. Amol, can you please mute the person? Showed that in endometrium of 25% of women with recurrent miscarriages, spatial expression of progesterone receptors was different or deficient. Now, the progestational agents have been used for treatment of miscarriages since early 1960, even before there was knowledge of immunomodulatory properties of progesterone. Progesterones widely used are in 2 forms. One is dydrogesterone and one is progesterone. These are various studies done over various decades, and they all show. This is again a very preterm deliveries, date babies and small for date babies with use of oral dydrogesterone therapy, which is again a form of progesterone. Now, progesterone inhibitory binding factor. It has been seen that these binding factors are blocked, which leads to Th1 stimulation and miscarriages. In normal pregnancies, these factors are which helps in the progression of a normal pregnancy. Now, this progesterone-induced blocking factor leads to asymmetric antibodies formation, which leads to Th2. That is, Th2 response dominates and reduces the natural killer cell activity. So, what does do in pregnancy? It is basically an immunomodulator. So pro-inflammatory center, it effectively sustains embryos, non-inflammatory T helper 2 cytokine, improve the blood flow and oxygen supply, and does it retain progesterone, bringing shift in cytokine production, suppresses production of pro-inflammatory cytokines, and upregulates the production of anti-inflammatory cytokine, that is interleukin 4. These are again various studies showing the adverse outcomes if the interleukin-4 levels are high. Interleukin-10, which are again all inflammatory cytokines. So a shift from pro-inflammatory T helper cell, that is Th1 cell, dependent cytokines to Th2 dependent anti-inflammatory cytokines seems to be a characteristic of successful pregnancy, and supplementation of dydrogesterone during early pregnancy may modulate this balance. Also, it helps, I've already mentioned, it increases the nitric oxide flow, thus lowering of the uterine arterial systolic and diastolic ratio and vascular resistance. It improves the endometrial blood flow and provides adequate oxygenation and nutrient supply to the developing embryo. Since 2015, the Gynec Endocrine Society have been supporting the use of oral dydrogesterone, and it has been recommended for use of preventing miscarriages in early pregnancy. These are again various studies showing the use of dydrogesterone with other drugs like HCG, then with placebos and with vaginal micronized progesterone, and they all indicate that use of dydrogesterone has a significant reduction in the recurrent pregnancy losses. Foxy recommends for recurrent miscarriages, if oral route is to be preferred, it has to be dydrogesterone 10 milligram twice a daily till 20 weeks of pregnancy. And if vaginal route is preferred, then it is micronized progesterone 400 milligram vaginally till 20 weeks of pregnancy. Again, this is a chart which indicates that when dydrogesterone was used till 12 weeks of pregnancy, it significantly reduced the miscarriage rates. Until 20 weeks of pregnancy, again the same. Also, various other studies indicated that it helps. Significant reduction of miscarriages was noted as compared to placebo or no treatment. So in 2015, the European Progesterone Club guideline for treatment of threatened miscarriages stated that for women presenting with clinical diagnosis of recurrent miscarriages, 3 or more, there is a reduction in rate of miscarriages with use of dydrogesterone. There is some evidence that the oral dydrogesterone initiated when fetal heart action can be confirmed may be effective. Vaginal progesterone does not improve live birth rates in women with unexplained RPLs. Sorry. Now, comparing it with micronized progesterone, the advantages, the dydrogesterone is selective for progesterone receptor and thus avoiding other receptor-related side effects. Also, it can be used orally, so it is better tolerated and requires 10 to 20 times lower dosage. Oral micronized progesterone is associated with risk of cholestasis during pregnancy, and vaginal progesterone is also metabolized in liver. These differences translate into clinical benefits. So these are again various studies with comparing dydrogesterone with vaginal micronized progesterone use, which show higher pregnancy salvage rates than with dydrogesterone as compared to micronized progesterone. And abortion rates were significantly less. Even the safety profile, because there were few documents in between stating cardiac abnormalities noted in patients who were put on dydrogesterone. But then again, the safety profile was established and it was only area specific because of the high risk population. So dydrogesterone supplementation in women with threatened preterm delivery. We have already seen that it impacts the cytokine profile, the hormonal profile, and progesterone-induced blocking factor, that is PIBF factors are affected. So thus dydrogesterone treatment of women at risk of preterm delivery. It can also be used in patients with who had a previous history of preterm delivery or have or are high risk for a preterm delivery. Is increased, results in increased production of PIBF and interleukin-10 concentrations, and lowers the concentration of interleukin natural killer cells and interferons. Dydrogesterone supplementation during first trimester has also been shown to significantly reduce the incidence of gestational hypertension, especially in primigravida. Now, this could be because of its effect on the decreasing the resistance of the uterine arteries because of the nitric oxide levels which it increases. This was stated that dydrogesterone and HCG significantly reduce the abortion rate as compared to untreated controls. So it's used in miscarriages, that is recurrent or habitual pregnancy losses. Now, doses. Dydrogesterone can also be used for threatened abortions. Now, for threatened abortions, the dose required is more. The moment the patient comes with a history of bleeding or you suspect a threatened abortion, 40 milligram is given stat and then 10 milligram every 8 hourly till the symptoms remit. For habitual abortions, that is for recurrent pregnancy losses, as a prophylactic measure, you start with 10 milligram twice a day till 20th week of pregnancy. It is not 12th week of pregnancy, but till 20th week of pregnancy, you have to continue. So dydrogesterone is more effective than standard supportive care or placebo and demonstrated a positive trend towards being more effective than vaginal micronized progesterone in management of threatened miscarriages and recurrent pregnancy losses. This I've already explained that how it is different and it has an advantage over natural micronized progesterone. Foxy gave a statement on use of progesterones in 2015. So progesterone support in recurrent pregnancy loss and threatened miscarriages. It states that progesterone support that could be vaginal micronized progesterone and dydrogesterone is beneficial in women presenting with clinical diagnosis of threatened miscarriage with relative risk reduction in miscarriage rate of 47% with use of progesterone. The dose of progesterone that are generally used in clinical practice as per current evidence are as follows. So for threatened miscarriages, micronized progesterone, 400 milligram per day vaginally till bleeding stops, and dydrogesterone 40 milligram loading dose followed by 20 to 30 milligram daily till 7 days after bleeding stops. Now, one very important point is there is no role of progesterone supplementation in normal, healthy, pregnant women for prevention of miscarriages. So if the patient is not a high-risk patient or the patient has not documented recurrent pregnancy losses or habitual abortions or threatened miscarriage, then we are not supposed to use progesterone in a normal, healthy, pregnant patient. To conclude, overall, dydrogesterone use in pregnant women with a history of recurrent miscarriages improved several pregnancy outcomes. Dydrogesterone is recommended by guidelines for prevention of recurrent miscarriages, and treatment of first trimester threatened abortion without a history of recurrent miscarriage with dydrogesterone appeared to be efficacious in improving the chances of pregnancy advancing beyond 20 weeks. Thank you so much for your patient hearing. Dr. Meenakshi?
Dr. Uday Kumar?
Yeah.
Yeah.
Thank you, Dr. Navneet ma'am, for your very important topic, for giving lecture on very important topic, that is recurrent pregnancy loss or recurrent miscarriages. Thank you, ma'am.
Thank you. Thank you, BMA, for inviting me for the lecture. Thank you so much.
Over to you, Amol sir.
Uday Kumar sir,
Yes, sir.
please invite next speaker.
Yeah. May I introduce our next topic lecturer, Dr. Sandeep Patil. Dr. Sandeep Patil sir is a university topper of first batch of MUHS University Nasik for DM cardiology in 2009. He is also fellow of European Society of Cardiology. He is working as senior international cardiologist and HOD Department of Cardiology, Bhaktivedanta Hospital, Mira Road since 2017. Worked as assistant professor in Department of Cardiology, BYL, Nair Hospital and TN Medical College, Mumbai for 8 years. He has vast experience of interventional cardiology in the form of complex coronary intervention, pediatric cardiac interventions, and pacemaker implementations since 10 years. Was postgraduate teacher of DM cardiology for MUHS University at TN Medical College and Nair Hospital, Mumbai. He has published articles in national and international journals, including the Lancet. Thank you, sir.
Yeah, thank you for this exhaustive introduction of mine. Thank you, BMA, for giving me an opportunity to present a common topic. Today, we are going to highlight some important treatment modalities, that is triple drug combination. Here we are discussing cilnidipine, telmisartan, and chlorthalidone in treatment of hypertension. So I have chosen this topic as hypertension is very common in our clinical practice, and we should have some idea regarding various combinations. So as we know, hypertension is a silent killer and is a leading cause of death. It's a major risk factor for heart disease, stroke, and diabetes. By 2025, it is estimated that around 1.5 billion people will have hypertension. According to 2015 AHA, this is alarming. Over 75% of population aged more than 40 years will have elevated blood pressure, because the definition of elevated blood pressure is now substantially changed. In that, almost 65% will be 40 to 60 years, and more than 60 years, 84% will have an elevated high blood pressure. Why this is important? The treatment is also important because we have some figures, because if you see the cardiovascular mortality, it doubles with every 20/10 rise in the blood pressure. That is 20 mmHg rise by systolic and 10 by diastolic. If you see, it will rise by doubling the risk of cardiovascular mortality. And treatment is equally effective. If you reduce it by 10/5, that is 10 mm systolic and 5 mm diastolic, you will get 40 to 50% lower risk of cardiovascular death and 50 to 60% lower risk of stroke death. So if you see the ACC-ASC guideline versus ESC guideline for hypertension, these are the values which we consider as a elevated blood pressure. AHA has little stringent guidelines. Office, daytime, blood pressure more than 130/80, they call it as an elevated blood pressure. Nighttime more than 110, 24-hour mean more than 125, and home BP monitoring, which is now in corona, it is very common. More than 130 is considered as an elevated blood pressure. While ESC, European Society, has little higher values. Office BP they consider as a significant when it is more than 140/90, daytime more than 135/85, nighttime more than 120/70, 24-hour mean more than 130/80, and home blood pressure more than 135/85. So why it is important? Because why the combinations came in the treatment of hypertension? Because a report says that only 37% of hypertensive patients in US achieve conservative goal of less than 140/90. So this is how the blood pressure treatment is. Even in US, people are not getting the target blood pressure. About 70% of hypertensive patients require combination of at least 2 antihypertensive agents to reduce the blood pressure levels below the recommended goals. So combinations are quite commonly used in our practice, so we should have some knowledge regarding the various combinations. So why to choose combination? Why not a single therapy? Because drug therapy directed at one component evokes compensatory response. So we should have a justified combination. So what are advantages of this combination is, it will lower the dose of the medicine so that the side effects will be reduced. It will improve the compliance because patient has to take a single pill. It will minimize the side effects because they are compensating for each other drugs and the doses are lower. They will have a synergistic effect also. We will have a superior BP control, and they will be cost effective because taking individual drugs versus combining the drugs, definitely the cost will reduce by almost 25%. So these are advantage of combining the drugs. So what all the other advantage also, we will have a greater reduction in the blood pressure, even reduction in the adverse effect. As we know, if you use a RAS inhibitors, they prevent the pretibial edema induced by calcium channel blockers. If you have a combination of RAS inhibitors, that is ACE inhibitors or ARB with calcium channel blockers, the edema, which is a side effect of calcium channel blockers, will be compensated by RAS inhibitors. So this is how it benefits mutually to each other. Then several pathophysiological mechanisms of increased blood pressures are blocked at a time if you are using a combination. Greater protection to target organs, faster control of blood pressure. The combination may have some other effects other than the antihypertensive agents like anti-inflammatory, metabolic, anti-counter regulation, diuretic counteract the retention of water produced by vasodilators. This is how they help each other. And RAS inhibitors compensate for renin release by diuretics. So what is the rationale for triple combination? That is ARB plus calcium channel blockers plus diuretics. These are the guidelines. If you use a single pill, start with a ACE inhibitor combining with a calcium channel blocker or a diuretic. Monotherapy for certain conditions, like if the blood pressure systolic is less than 150 or patient is very old and fragile. Then step 2 is you have to use the triple combination. What is the preferred triple combination is ACE inhibitors or ARB with calcium channel blockers and diuretic. If in spite of that, after 6 to 8 weeks, your blood pressure is not achieved, that is above 20 by 10 mm above the target level, then definitely we have to add spironolactone in that, and other diuretics also can be used. Alpha blocker and beta blockers are also drug of choice. Nowadays, beta blocker we don't prefer as a antihypertensive primarily, but certain indications where it can be used as an antihypertensive drug also, that is heart failure, angina patients, post-MI patients, atrial fibrillation, young women, or a planned pregnancy where the beta blockers have a role in hypertension. So what is the rationale of the combination of these antihypertensive drugs? Because we have to know the mechanism of action of various drugs, then we'll know the rationale behind the combining these drugs. As we know, cilnidipine, it has a dual LN type of calcium channel blocker, causes vasodilatation and blood pressure reduction. While chlorothyronidone is a thiazide type diuretic, it has a 24-hour BP reduction, first line drug in hypertension. Telmisartan, which is commonly used, all we know, it binds to AT1 receptor in vascular smooth muscles and adrenal gland. It causes vasodilatation and blood pressure reduction. So all three have a cardioprotection. How it is? Cilnidipine suppresses the cardiac sympathetic overactivity via blocking of N type of calcium channel blocker. So there will be no reflex tachycardia as we see in nifedipine. It improves the LV function. Chlorothyronidone reduces LVH by reducing the systemic vascular resistance. Telmisartan will reduce the cardiovascular mortality and morbidity, and it reduces the LVH also. As far as renal protection is concerned, which is a goal of every antihypertensive drug, all three have a role. Cilnidipine, it suppresses the glomerular hypertension by dilating both afferent and efferent arterioles. It reduces the proteinuria. This is how advantage of cilnidipine over amlodipine. It benefits in patients with proteinuria, and it has an additional renal protection mechanism. Chlorothyronidone indicated in edema associated with renal disease, including nephrotic syndrome. It reduces the risk of calcium oxalate kidney stones also. These are additional benefits we get with chlorothyronidone. Telmisartan, it reduces albumin secretion. It prevents transition to overt nephropathy. So this is an additional benefit of telmisartan. If you see the metabolic profile, how we are getting benefit of combining all these three drugs is, cilnidipine, as it improves the insulin sensitivity. This is quite good information, as all we know it's a calcium channel blocker, still improves the insulin sensitivity, possibly due to its vasodilatory mechanism. Chlorothyronidone is a key component of treatment in nephrogenic diabetes insipidus. And telmisartan, as we know, it's a partial agonist of PPAR gamma, which causes insulin sensitization, and it delays the onset of diabetes. So all those who are pre-diabetic and risk of diabetes, telmisartan works better. So in short, regarding the telmisartan, as we know, is an angiotensin II receptor antagonist. And this was the first brand of telmisartan, Micardis, which was launched in 1999. And the dose is once daily. We should not use twice daily. Maximum dose is 80 milligram. Half-life is 24 hours. So it has a longer half-life. That's why used in OD doses. So this is how the advantages of blocking the angiotensin II receptor, because angiotensin II stimulates the aldosterone secretion, which causes fibrosis, sodium retention. And it also stimulates the muscle hypertrophy, in the heart also and fibrosis in the heart. It causes the sympathetic outflow and vasoconstriction. So if you block all these angiotensin 2 receptors, then we will have a vasodilatation. There will not be any increase in the aldosterone levels, or sympathetic outflow will be decreased. So we have a benefit in heart, vessels, renal, so multiple benefits. If you compare this telmisartan with the other sartans, definitely telmisartan had an advantage of a longer half-life, 24 hours, and its early achievement of its maximum effect, that is 0.5 to 1 hour after ingestion. Bioavailability is better than losartan and valsartan, 43%. There is no food interaction. Route of elimination is majority biliary, so there is no renal interaction. So this is an advantage of telmisartan over other sartans. If you see the pharmacology, as we discuss this telmisartan as well as cilnidipine, why we are combining them? Because they are matching with the pharmacological effects. If you see the maximum effects, both cilnidipine and telmisartan, they achieve within 2 hours of oral ingestion. That is fast action. Half-life, they are comparable. Telmisartan is 24 hours, cilnidipine 20.4, that is 21 hours. And elimination majority is by biliary, that is no renal interaction. This is how we can, it is rational to combine telmisartan with an cilnidipine. So cilnidipine, as we know, has a dual L type of calcium channel blocker effect. As we know, if you block the L type of calcium channel blocker, they are located on the vessels, so we will prevent vasoconstriction and there will be vasodilatation. This is how it helps in reducing the hypertension. But the importance are N type of calcium channel, which are present on sympathetic nerve endings. So we have N number of benefits by blocking that. We will have a vasodilatation, there will be reduced in the heart rate, and the renal blood flow will also be increased because norepinephrine levels will be reduced in the blood. So this is how the cilnidipine benefits. So it's a dual action, dilates both afferent and efferent arteriole. So that's why it reduces the intraglomerular pressure and it prevents the renal injury, renoprotective effect, lower incidence of pedal edema. That is important. Amlodipine, almost 10 to 20% patients, they complain of edema. So cilnidipine will not have that edema. Reflex tachycardia, which is seen with the dihydropyridine type of calcium channel blockers, is also not seen with the cilnidipine. So these are advantage over other calcium channel blockers. So chlorthalidone, nowadays we are coming with more use of this drug, because if you compare, previously we used to use more of a hydrochlorothiazide as an antihypertensive drug. If you compare with the hydrochlorothiazide, chlorthalidone definitely has an advantage of a long action, 40 hours, and bioavailability is almost matchable. But if you see the potency, BP reduction of chlorthalidone is definitely very high as compared to hydrochlorothiazide. Average is 12.4 systolic and 7.2 diastolic, where it is almost 60-70% less in hydrochlorothiazide. As far as hypokalemia, hyponatremia, and hyperuricemia, it is definitely seen, but not that common. So, but we should avoid in extreme ages also. So what is the mechanism of action of chlorthalidone? It acts on distal tubule, causes sodium and water excretion, decrease in blood volume and cardiac output. That is how it reduces the blood pressure. So there are some clinical evidences of these drugs, like cilnidipine. If you see the cardioprotection and ambulatory blood pressure control and home blood pressure control lowering by cilnidipine, that is Achieve-1 trial. The objective was to study the effect of cilnidipine on sympathetic hyperactivity, which is more seen in the morning. So what they have found is the cilnidipine has more reduction in the systolic blood pressure, and the morning systolic blood pressure is significantly reduced with cilnidipine. So majority of patients have a problem of early morning hypertension, systolic blood pressure. If you give a cilnidipine, then definitely the early morning systolic blood pressure is reduced. If you see the telmisartan cardioprotection, this is the trial published, where multicentric trial, 14 weeks study comparison of telmisartan and ramipril, that is ACE inhibitor, with mild to moderate hypertension. It is to compare the efficacy of both the drugs in reducing the diastolic and systolic blood pressure. What they have found is telmisartan offers superior reduction in last 6 hours systolic blood pressure. As I was discussing, it has a very longer half-life, 24 hours. So OD doses are enough, and early morning hypertension is definitely last 6 hours blood pressure is also important. That is significantly reduced by telmisartan. So telmisartan has a potential to prevent acute cardiovascular and cerebrovascular events. If you see the renoprotective effects of cilnidipine, so this is a trial where they have compared amlodipine versus cilnidipine in preventing the renal disease, that is proteinuria. So what are the results are? Cilnidipine reduces the proteinuria by 14%, whereas amlodipine increases it by 14%. So cilnidipine appears very superior as compared to the amlodipine in renoprotective mechanism, that is proteinuria. If you see the renoprotective effects of telmisartan, this innovation study objective was to assess whether or not telmisartan elicit benefits on progression of microalbuminuria in normotensive and hypertensive patients. So what they have found is it is 38% superior in reduction of renal proteinuria. So it offers superior renoprotective effects and prevents transition from incipient to overt nephropathy. So metabolic profile of cilnidipine, if you see, definitely amlodipine doesn't have an insulin sensitivity mechanism, and cilnidipine has insulin sensitivity mechanism. It improves the insulin sensitivity by 21%. So this is how the metabolic benefit of cilnidipine over the amlodipine. So this is an on-target trial. This is an important trial to assess the efficacy of telmisartan in preventive cardiovascular events in individuals at high vascular risk. So what they have found here is telmisartan is non-inferior to ramipril in reducing the incidence of primary composite endpoint, that is cardiovascular death, non-fatal MI. And there was no significant difference between telmisartan and ramipril in preventing the secondary outcome. And the prevalence of LVH is significantly decreased in both groups. If you see the efficacy, it is non-inferior, means equally effective to the ramipril. So why we prefer chlorthalidone nowadays? These are 2020 hypertension highlights, where the chlorthalidone is preferred over the thiazide like diuretic, that is hydrochlorothiazide, because chlorthalidone is long-acting diuretic. That is an advantage over the hydrochlorothiazide. As I was discussing, beta blockers are not indicated as a first-line therapy for age more than 60 years. So preferred choices are ACE inhibitors, long-acting calcium channel blockers like cilnidipine, beta blockers in specific indications, and single pill combinations where the blood pressure is not achieved by higher doses of single drug. So to prevent the side effects and to reduce the burden, also we have to combine the drugs in a single pill. So this is how cilnidipine is potent as compared to the hydrochlorothiazide. Here it shows more reduction in the mean blood pressure at 12 weeks as compared to the hydrochlorothiazide. So even the low dose thiazide in hypertension, 24-hour and 9-time ambulatory blood pressure after 12 weeks is significantly reduced with CTD as compared to the hydrochlorothiazide. So this chlorthalidone is, there is a trial, that is CLICK trial. This is an interesting trial because they have tried chlorthalidone in CKD patient, stage 4 CKD with uncontrolled hypertension, and the results are yet awaited. Including this will be an interesting trial because we try to avoid this drug in a renal failure patients, but it has a renoprotective effect. If it comes out to be positive, then definitely this drug will also be indicated in CKD patients. Thank you.
Thank you, Dr. Sandeep Patil, sir, for giving such an informative lecture. So there are some questions.
Can you please ask questions?
Yeah.
Meenakshi?
Yes, sir.
There are questions in the chat box.
Yeah.
Please ask.
Is low dose of chlorthalidone better than SCTZ in Indian patients, sir?
Yes, 6.25 milligram dose is better than the hydrochlorothiazide because it is potent and long acting. That is how we prefer chlorthalidone over hydrochlorothiazide.
Your experience using azithromycin plus ARB?
Yeah, definitely. It's Azlidipine is a new drug. Their use is quite not used in many patients, but definitely those patients who are on Azlidipine plus ACE inhibitor, longer acting, more potent, definitely a better drug.
Amol sir, is there any other question?
Yeah, sir, can you use this combination in patients with hyperuricemia?
Yes,
ATM may cause
definitely.
hyperuricemia, and clinidipine has shown promising effect in hypertension and hyperuricemia. Can you please comment on this?
Good question, because cilnidipine again reduces the uric acid. The hyperuricemia is another non-hypertensive benefit of these drugs. So definitely it should be preferred in patients who have hyperuricemia.
Also, there is one more
Sir,
question.
till now, how long you prefer triple combination for patients? What about Telma for hypertension?
Yeah, as far as the triple combination is concerned, definitely it's not a first option. First, you have to start with a single drug, or else if the blood pressure is very high, if you are getting patients with blood pressure more than 170, 100, they are in stage 2, then definitely starts with a double combination and escalate the doses. And if it is still not controlled after 4 to 6 weeks, start a triple drug combination. And then definitely follow-up is required. As long as the blood pressure targets are controlled, we will be happy to continue with the triple drug. But simultaneously, you have to monitor the potassium level. You have to see for the postural hypotension. We have to see for the renal function also. If you monitor them closely and if you are getting the results, we are happy to continue, because it's Indian patients, as we know in clinical practice, they want less number of drugs. Cost should be less. So rather, we are the people where combination drugs are more preferred than the other people. So wherever it is required, the justified combination should be used.
Amol sir, any other question?
How is your experience using the chlorthalidone low dose with ARB combination in uncontrolled hypertension? Any benefit of low dose in Indians? Which will be indication for low dose of chlorthalidone?
Yeah, chlorthalidone as such is a potent antihypertensive. And if you see the telmisartan, comparatively, it's not that potent antihypertensive. So combination is justified. Only thing is both, we have to be little careful regarding the renal function here. And generally, the diuretics preferred patients are the patients with isolated systolic hypertension, that is age more than 60 years with a systolic blood pressure. So combination with telmisartan and chlorthalidone is a preferred combination in those groups also, or it can be combined with the calcium channel blockers also. So potency wise, it is more potent. So I will always prefer a low dose chlorthalidone rather than a high dose, because it's very long acting, as well as the potency is very high. Even if you use 6.25, average systolic blood pressure reduction is more than 14. So it's a good combination, telmisartan with chlorthalidone. Only thing is, with extreme ages, we have to be little careful, because you may have postural drop and renal deterioration also in such patients.
Last question, sir. Which triple combination you prefer other than clinidipine, telmisartan, CTL?
The other triple drug combination is cilnidipine. There are few companies which are coming with cilnidipine. Otherwise, telmisartan with amlodipine and hydrochlorothiazide is also a preferred combination. Sometimes we use beta blockers if patient is young and there is a tachycardia, then that can also be included with telmisartan, beta blocker, and hydrochlorothiazide also. So preferred combination is RAS inhibitor, that is ACE inhibitor, or ARB with calcium channel blocker with a diuretic, that is hydrochlorothiazide, or cilnidipine. This is the most common triple combination used.
Okay, sir. Thank you, sir. Thank you, Meenakshi.
Thank you, BMA, for giving me an opportunity.
Thank you.
Thank you, sir. It was a very informative lecture. Thank you.
Moderator for the next two sessions are Dr. Madhvi Jadhav, who is Post Secretary of Bhinder Medical Association, and Dr. Brijesh, who is Committee Member of Bhinder Medical Association. Over to Dr. Madhvi.
Thank you, Dr. Amol. I welcome Dr. Ashok Shukla sir, who is a senior gynecologist and medico-legal consultant. He is consultant and director of Sai Ashirwad Maternity and Nursing Home. He is honorary consultant of Wokhad Hospital and Meera Bhayandar Municipal Corporation Hospital. He is a committee member of AFG, past committee member MOGS, Vice President AMC, Chairman IMA Medical Legal Cell, and Trustee of Bhayandar Medical Association. I welcome Dr. Ashok Shukla sir.
Thank you, Madhvi. I think so. We'll directly go for the share screen. You all can hear me, no?
Yes. We can hear you, sir.
Yeah, I'll just start. Just hold on. I'll check technical and I'm able to start the screen share. Slideshow, I'm not able to start. I'll just bear with me. This laptop is my son's laptop, which I'm not able to adjust. You can see the slides. I can just run the slides. The second slide and third slide I'll do.
Yes, sir.
Okay, na? Because
yes.
Okay, thank you, BMA, for inviting me for this program. Today we will be talking about a very important scenario, that is the medico-legal safety precautions what you can take in our private practice. Now, why we in today's era are talking about medico-legal? See, we have so many clinical topics. You heard fantastic talk by Dr. Sandeep sir. Why? Now, reason is because the whole medical practice scenario has changed. The older time, the family physician doctors or the consultant, maybe the family physician doctors used to be like a god to the patient. Patient, jo doctor bola, wo sahi. That was their dictum. Whatever medicines doctors to advise, if the doctors to say this problem occurred, this can happen, okay, doctor, you did the best. Now the things have changed. The whole era has changed. The thought process of the patient, the doctor-patient relationship, everything has changed. So what is the main problem? The quality of healthcare system. If you see the quality of healthcare system, the patient-doctor ratio is very, very poor. And because of which there is a huge workload on the government hospitals, on the other clinics, because of which a lot of patients go towards the private sector. Now there are a huge amount of load to the private setups where the quality of care sometimes get compromised, or the doctor tries to do whatever best can be, but some error here and there in paperwork or somewhere happens, which unnecessarily lands up the doctor to the litigation. You will see the role of media. Already media has started projecting doctors at a villain at a different movies. It's a hot topic. Always they'll try to depict as if the doctors are always doing something which is very illegal, doing wrong things. So now patient, when comes to the OPD, sees you with all suspicion. The moment you say ये दवा लेना है, ये लग रहा है, ये X-ray कराना है, they'll start seeing at you. जरूरी है. Moment you do an MRI or CT scan, you advise, and the patient comes and you say the report is normal. The patient feels पैसा waste हो गया. Normal है, क्या फायदा CT scan करा के? They don't understand that they should be happy that the report has come normal. They don't have any major disease. But that's the problem. The doctor-patient thought relationship is also changed. Next. Now, today what we are going to discuss is the medico-legal responsibilities in general practice. I have classified into different parts because these are the important parts which you have to understand: the OPD record keeping, the certificates, the referral letters, home visits, cause of death, and some court judgments along with this to just make you feel that why these things are important. So if we go to the OPD record keeping, Now becomes very important. It starts from the patient entering in your waiting room, the good rapport and communication skill of your receptionist to pacify or make, because a lot of time what happens, there is a huge amount of queue. The patient is waiting, the doctor is already seeing some patient, the patient's relative is panicking that mera patient ko pehle le lo. A good communication skill slightly relaxes the patient relative, and if the receptionist feel that this is an urgency patient, the family physician allows that other patient to come in between before, without creating any ruckus or violence in the mind of the other patient who is waiting in the line. So good communication skill. OPD paper, very important. A detailed history taking, a proper full name, age, address, the emergency contact number. Now these are very important, which has to be there. Then your clinical findings after the history taking, your clinical findings with your general examination, whatever you have done the examination, which you feel the salient features, you should mention. I understand in OPD practice where family physician sees around 50 to 70 to 100 patients per day, they might feel ki Dr. Shukla, this would be very difficult for us to implement in theoretically and practical way what you are saying. But I think so time has come that we have to increase our efficiency, maybe divide our work, keep two receptionists, filter the work, divide the work, and then you have to. Otherwise, that will be a big problem. If one patient files a case, whatever you have earned, if your papers don't prove that you have taken utmost care, you'll be spending a huge amount of money in paying compensation as well as the mental stress to you and your family while undergoing this litigation. Then in your examination, you have to see that your paper should have a differential diagnosis. So a lot of time when the patient comes, you are giving a medication. So you have some differential diagnosis in your mind. You should mention. It doesn't make a difference. You can write 2 or 3 differential diagnoses. It helps that you have discussed with the patient. Treatment. Whatever giving treatment you are giving, if there are 2 school of thoughts or 3 school of thoughts of the treatment, and you feel that the patient has to be told about the outcomes or the options available, then your OPD paper should also mention that the treatment modalities were explained to the patient, and then the patient finally we decided to do this. This is very important again, because if tomorrow something happens and you are trying to conservatively manage something, and then something doesn't work, the patient will say, I was never given an option. I was told this is the only method. Doctor ने मेरे को कभी नहीं बताया कि आप ये कर सकते हैं. So your paper also should have that. Investigations, very important. See, if you are advising some investigations, it should be properly mentioned on the paper, not only on your referral sheet. Sometimes you don't mention on your OPD paper. You mention on your small chit or a prescription card. Now, if the patient doesn't bring, you don't have any documentary evidence that really you had suggested that investigation. The patient might say, मेरे को sonography नहीं बोला. That patient might turn up to be an ectopic. Patient might say, मेरे को X-ray नहीं बोला. That patient might turn up to be COX or maybe pneumonia or something. So you're mentioning that whatever test you have told should be there. If the patient on the follow-up visits shows you the report, you should also mention the date of the test. Because what happens if the patient was advised a particular test, patient was supposed to come follow up with the test next day, patient followed up after 10 days, did the sonography also after 7 days. That means if there is some problem which occurs, you can at least justify that I had told you to do sonography next day, but then you waited for 7 days and now these things are happening. But your paper should speak. Documentation. Your paper should speak what you have explained to the patient, because that's the only evidence you have. Always important that copy of OPD paper should be there. And if a follow-up patient doesn't follow up in time, for example, you ask the patient to follow up after 7 days, patient follows after 1 month, you should write on paper again, patient was advised to follow up after 7 days, but patient for whatever reason, patient felt better, so patient herself or himself came after 1 month. And you can mention, because tomorrow if there is some problem which arises from the primary disease which was detected by you on the first visit, then you have a justification that advise the patient to follow, but the patient didn't follow. So your paper should speak what you have done. Copy of OPD paper always has to be kept. This is the thing which I think so everybody has to do. I remember my old family physician when I used to be in my schooling days. Dr. Jitendra Parekh, family doctor in Borivali. I used to stay in Borivali. I used to remember, they used to have a family, family patients. So they had a family के नाम पे वो diary. Then diary में they used to enter every page पे बेटे का father का नाम के हिसाब से. And then whenever you go for next visit, they used to open the diary. हाँ, last time okay आप अच्छा है, इस बार अभी okay ये दबा दिया. So they used to have a method of record keeping. They also used to have. The only thing is they never used to give to the patient. they used to keep with them except the medication, because the medication used to be dispensed from them, and whatever they used to write, that was the only prescription what the patient had. But the patient never knew what things are. Now the law says it's always better the patient should have a proper OPD paper, because maybe tomorrow your clinic is closed and the patient is not having, is not satisfied. Patient is having some problem, and patient wants to go to some other doctor. Now that other doctor will not come to only what you have given, but what was your findings and what was your thought that why you had given those medicines. So today I feel OPD paper has to be given to every OPD patient who sees, I know the cost will slightly go up, charges has to be increased if we feel the costing is more. Digitalization is again a very good way of maintaining the record, as well as maintaining a copy of record and then easy access to the record. In the long run, I think so one clinical establishment and other laws come, everybody would be forced to do digitalization, and earlier we learned to keep digitalized record, it would be better. Handwriting. Now the other biggest problem is that we write, sometimes the family physicians or consultants write prescriptions in such a matter that sometimes they themselves are not able to read. Now why this is so important? See, if a patient comes to you after 6 months and you have given them the OPD paper, you had written something, and if you yourself are not able to read what was your interpretation that time, or what was the medications that time, or you have issued, there is some litigation and you have been asked, and the on-mighty judge asked, okay doctor, read your OPD paper and what you felt. And if you are reading very slowly because you yourself are not able to recognize what you have written, then it becomes very difficult. Then it doesn't show good in the law, in the eyes of the law, that you are not that much sincere in writing eligible good handwriting. And in those things, your prescriptions also might be misinterpreted, or some wrong medicines might be given. And the chemist who has given the wrong medicine might take cover of your handwriting, saying that this is the handwriting doctor has written, so I thought this is the medicine. Not necessarily the chemist who's just accompanying the family physicians or the consultant's clinic in the OPD will be the place where the patient might go. Patient might go to any chemist, and it can happen. Specifically when there are medications whose brand names are look alike and hear alike, they sometimes are seen similar, or their spellings are similar, which sometimes might give a wrong medicine. And a lot of time the chemists have a drawer which are labeled ABCD format, and they might do an error. So I think so this is about the OPD paper which I would like to say. Then the certificates. In the OPD paper, I would like to add one more, identification. I have taken a slide later, so we'll discuss the certificates. Now, as I told today, only I'm going to give the brief precautions what you can take, because every part is like a different talk. We can have a whole session only on OPD paper. We can have a whole session only on certificates. So these are some short certificates. There's a huge list of certificates. Now, these are the commonest certificates which we find. Under treatment certificate. Now, a lot of time patients come, they are taking treatment, they will suddenly come and say, doctor, I want the under treatment certificate. So your under treatment certificate should be properly printed format, always advisable. Instead of writing in your handwriting, you should have a printed format, ideally with a carbon, so that you automatically create a carbon copy with that, or a digital format, so when you can just add the names in the printed format, take a print and save as a folder in your laptop or your computer. In the printed format, the name of the patient, the full name of the patient, the proper age of the patient, the what disease diagnosis you had felt, and the reason why you're giving the under treatment certificate, because this patient is going to come also for a leave certificate, 2 weeks leave, 3 weeks leave. So your date and time should be properly mentioned when you're issuing the certificate. Your OPD paper also should be mentioning that patient really had come to you. Sometimes the patient comes on the first visit, shows you, and immediately ask for the under treatment certificate. Some time patient comes to you, takes the treatment, and suddenly after 10 days comes to you and say, doctor, I had taken treatment 10 days before and I want a under treatment certificate. So you have to be very careful how long, why now the patient is asking after 10 days, whether the patient is going to unnecessarily harass you, or by filing a complaint, that's the reason patient wants to prove, or patient wants to submit to the office. See, normally certificates are required at 3 places. Either patient wants to complain against you, or the patient wants to have take a leave from the office, or claim your charges from the insurance company, or some trust or somebody who has promised them to refund some money, or it's going to be gone to a bigger center for the treatment, and because your name is mentioned on the chain of events, so the doctor wants, the insurance company wants, then the unfit certificate. Lot of time I have seen people, family physician, patients lot of time requesting, डॉक्टर वो मेरे को फिटनेस तो दे दो सर, लेकिन क्योंकि छुट्टी मेरे पास बचा नहीं है, मेरा सेट निकाल देगा या तो फिर वो मेरा लीव विदाउट पे हो जाएगा, तो मेरे को ना लाइट वर्क काम दे दो, उनको बोलो हल्का काम करने के. See, you have to be very careful when you are issuing such certificates where you are saying light work. No, because it's very difficult to tell light work. See, and you should know a profession that person is. Now, if he's a person is a driver, he's driving a car, or he's a driver driving a ST bus. The moment you say light work, he cannot drive. So that means he'll be in the depot doing the clerical work. So sometime the patient says कि मेरा ऑफिस सेकंड फ्लोर पे सर, मेरे को आपने सीढ़ी चढ़ने को मना किया, तो light work. So you have to understand what type of certificate you are giving, because today the companies also have their own legal department. They will ask you, doctor, exactly what you meant. If you feel the patient feels supposed to take rest, why not you give proper leave certificate instead of saying that light work and heavy work for 6 months. Fitness certificate, again very important. Sometimes patients come and say, doctor वो मेरे को infection था, बुखार था, you have given me the certificate 15 days, मेरे को और 10 days का चाहिए, अभी ठीक नहीं हुआ, and fitness भी दे दो. Now a lot of time today only you are writing, now at present the patient is having fever or and I have patient feeling weak, take rest, you are fit to join after 15 days. So after 15 days, in this 10 days he might deteriorate, his fever might go up. So normally we suggest, ask the patient to come again, examine, really patient is fit, and that time you can give fitness certificate. There is no harm, patient can visit. You do not give a fitness certificate in advance, 15 days later, 20 days later, unless until it's a maternity connected in that. So we normally say she is eligible for leave as per the rule, because every companies have different rule. Then school kid fitness certificate, a lot of time family physicians get that school ka form, school join karna hai, and vaccination card, and I'm fit. So a lot of them we feel कि it's very simple certificate. Okay, कोई problem नहीं, बच्चे को दे दो. See why the school people have now started insisting for the fitness certificate before they join. See, because there are a lot of incidences in the past, around 2 or 3, where the kid suddenly had some problem while playing PT, and suddenly they come to know the child had a heart disease, and the child expired in the school premises. Then the school people have that allegation that why you made my son run. So all those things have come. The child falls sick, child has an asthmatic attack, and they didn't knew that this child is having asthma. So they suddenly asthmatic attack, they didn't know which pump, which contact number to be given on the emergency. They suddenly the child had fever, and the nurse in the school gave the paracetamol syrup, and then the child had an allergic reaction to ibugesic plus, for example, and then they say the child had an allergic past history. So that's the reason this certificate they have started, and then that's the reason we say you should take a proper history. If you have not seen the child in the past, ask all the history from the mother, that show the pediatrician paper, what you have seen, is the child allergic, and then it should be properly documented, and then that OPD paper ka xerox bhi you keep as a record on what basis you have given fitness certificate, and then charge for your fitness certificate. Sometimes the patients come for mentally sound certificate because they want to issue some will, or they want to do, their father wants to send them to get some money from, it's etc. I always say family physicians should be very careful while giving this. It's always better to use psychiatrists and psychiatrists for issuing such certificates, slightly more safer, because in one visit you cannot assess the person's mental condition unless until the patient is your old patient. Reference. Now, when you are referring a patient as a family physician, you are referring a patient. Sometimes you feel that I have to refer the patient for elective or maybe emergency. You feel this patient needs an emergency care, or this patient needs a surgery, or some type of super specialist care. So you refer. So the reference letter also should be a proper, because see, ultimately it shows the image of the family physician who is referring. So the reference letter should be a properly printed letter with the full name of the family physician, full name of the patient, the full name of the family physician, the address, the phone number, the name of the full name of the patient properly written, why you are referring the patient, whether it's an emergency, whether it's an elective, whether it was for surgery, what was your clinical diagnosis or differential diagnosis, what you were suspecting. Then in short, some amount of the clinical history, what the patient had really shown to you with these symptoms, and then also keep a copy of that reference in your record keeping. Now this becomes very important, and I always feel better that the family physician feels that this is a slightly critical, or this patient should go. So always give a call to the consultant or the hospital where you are referring, and you can tell them, sir, so and so patient I'm sending, patient is slightly breathless. patient is accompanied with the mother. I have told them immediately, just inform your receptionist when they come, please see her out of the queue. She needs, it helps. The consultant then immediately informs the receptionist, so and so patient is coming. There is some amount of breathless or high grade fever, 103, 102. Immediately check her temperature, check her oxygen saturation, immediately inform me, and the consultant attends. The patient feels very good. When I reached there was a huge queue, but that doctor had told, and then that consultant doctor immediately took me and gave me the treatment. And catastrophe or complications in the sitting in the waiting room can be avoided. Now, why these reference letters are so important? I'll give you two court cases judgments. In one of the case, a family physician saw a patient, and then on clinical examination, he found that the patient is having jaundice. So he wrote a letter to a hospital and he told, please go to so and so hospital because I feel you are jaundice and you get your investigations done. Patient didn't went, no, delayed, went home and thought कि नहीं वो doctor ने बोला 4, 5 days, 6 days. Around 3 to 4 days the patient waited, and after 4 days the patient suddenly deteriorated. And then immediately the relatives took to the nearby hospital, and the patient was already having a very high grade jaundice, liver failure. Patient died. The moment the patient died, the relatives started alleging that this family physician they had shown 4 days prior, and the family physician told everything is fine, and now how this has happened, you pay me money, you are the mistake. And then the family physician had that paper copy, and then he removed and he showed, I think so, you had come 4 days back. He told, yes, I think I have written on this that I am suspecting jaundice, and I had advised that you are supposed to go immediately to the hospital, to a well-equipped hospital, and you need admission. And then the relatives who had come with a lot of anger because they didn't knew the case, and then they got settled, and they told, then they started firing the relative who had told that this doctor had not advised, and they told, अरे तुमको डॉक्टर ने तो बोला था, तुम झूठ क्यों बोलता है, ऐसा नहीं करने का. And then things got pacified. And so this much important, your OPD paper and your reference letter sometimes mix, because there was a reference letter also attached to that OPD paper of the doctor, of the patient, and a copy was also there in the OPD to the OPD records to show them, see, I have already written with the date and time also, and see, at that time only I had told, and in fact I had spoken to the doctor also, and this patient didn't went. Now I cannot call again the patient at home and ask where you have given go, where you have gone, because ultimately it's the patient's choice where the patient wants to take the treatment. Then reference to a quack. Now again, this becomes a very important. If a family physician refers to a consultant, a doctor who's not a qualified doctor or a quack, there was a judgment where the judge found when the patient had a complication because of the treatment from a quack, a non-qualified consultant, then the patient told that I was referred to that, I'm a layman, I was not able to understand. The court also made that family physician party of misguiding the patient and sending him to a wrong place when the patient had full faith on the family physician to follow. So this again became important, and the family physician was asked to share the money amount which was asked as a compensation. Home visit.
Sir, 2 minutes more.
Yeah. Home visit. The home visit, it's again very important. A lot of time we have so just simple, can I refuse home visit? Yes, you can refuse home visit. You can say I'm attending some patient, so I can't come at present. You can go to any other family physician. How much should be charged? It should be a genuine charge if it's an old patient, at least equivalent to the amount of time you spend. Your home visit is not good for the patient. You have to tell, because patient gets addicted to home visit, because there the infrastructure limitations are there. You wouldn't be able to examine the patient that well. So chronic illnesses patient, like onco patient who are oncotherapy, cancer patients, during COVID patients, specifically when you're doing home visit, take all those precautions, document on the paper that you have done home visit, and write all the things what you have mentioned. Cause of death. Now, cause of death, you should only give if you feel you can give, the cause of death. Otherwise, don't give the cause of death. You can refuse to give cause of death, and you can say, I don't know to give cause of death. Always see that 2 markings are there on your paper about the identification marks, and relative sometimes forces you at the gunpoint, for example, or anything, and you feel I was forced to give. You can go to the police station and complain next time immediately that I was forced, otherwise I didn't wanted to give. I always say your document and your staff and your receptionist should speak the same line. If there is a problem, the police comes, you should say, see the same line. You always should see this movie where the police argued, but things were all the same. Maintaining records for 3 years at least at present, the law says for indoor paper, there is no clear-cut guidelines for the OPD paper, but I always say there is no harm in keeping the OPD papers also. Miscellaneous CCTV installation should be there in the waiting room. In the examination room, it should not be showing the examination part, but in your consulting part also should be there. Emergency tray and kit and oxygen facility should be there because any drug or injection patient might have an allergic reaction. Expiry date should be properly checked. Samples specifically given from pharmaceutical company. Injections in the emergency kit, expiry date should be checked. Your qualifications, your licensing should be displayed in the waiting room. During COVID specific precautions, you should follow all the MBMC or government guidelines and display all the rules regulations outside, and so that the patients understand that you are following all the guidelines and whatever you are saying is for the patient benefit. Thank you for the patient's hearing. Thank you BMA and IMA for giving me this platform. As I told you, medical legal talks, every topic is a huge topic itself, but I try to concise and give small take-home messages where family physicians can take all those precautions and try to protect themselves and avoid landing up in litigations. Thank you. Thank you, everybody. Thank you, Posa madam.
Sir, we had some one question from the attendees. Till what time should we keep the OPD records?
Sir, if you see the ethics, the ethical guidelines, there is no exact guidelines mentioned about the OPD paper at present. In the Clinical Establishment Act, it is there. But if you will see the MCI guidelines, everywhere they have mentioned about indoor papers. But I suggest that everybody should maintain at least for the same 3 years. See, if this is the, ideally they have asked for 3 years. But the police case or issues which are under litigations, death certificates, FIR, police, you should maintain till the issues are over. So that's the reason now newer rules and regulations will make you store for the longer period when Central Clinical Establishment Act added. So I feel now we should go towards digitalization that will help us to protect the papers for very, very long instead of piling up in our OPD.
Okay. Thank you, Dr. Ashutosh Gula sir, for so many valuable inputs on medical legal issues faced during our clinical practice. Thank you, sir.
Thank you, sir. Thank you, everybody.
Sir, one more question is there.
Yeah.
If home visit patient found serious.
Yeah. So see, this is a very tricky question. That's the reason the first line I had written in home visit, you can refuse because a lot of time patients will call you gasping patients. But if you have reached, then as per ethics, you have to do whatever best you can. You have to escort to the patient to the nearest hospital, or if the patient, or wait till an ambulance comes with has a doctor accompanied. You have to treat the patient. You cannot leave a serious patient and say that I have seen the patient is serious. Now you take the patient wherever you want. I'm going back to my clinic. You cannot, because if the patient dies, and then you will be in the problem. They will say doctor had come, doctor would have done CPR, doctor would have done XYZ. So then your work is to take the patient as to the closest hospital as possible to save yourself. These problems mainly occurs in remote areas where there are less hospitals and less doctors also. There the catch-22 situation here, and you have too many hospitals as well as good government hospitals who can at least come for your rescue.
Thank you, sir. Vijay, sir.
Yes. Thank you, Ashok Shukla, sir. Our next speaker is Dr. Ratnaprabha Pisal Posa. She hails from Mumbai and possesses rich experience of 26 years in the field of dermatology, venerology, cosmetology, trichology, and laser technology. She runs 3 well-equipped laser and dermatosurgery clinics. She has done her MBBS from Grand Medical College and Sir JJ Group of Hospitals, Mumbai. She did her DVD from SET GS Medical College and KM Hospital, Mumbai, under the guidance of eminent Dr. Rui Fernandez sir and late Dr. Pushpa Gupte. She is currently the president of Binder Medical Association for the year 2020-21. She has delivered lectures and she has been a panelist in various scientific forums. She has delivered talks on role of telemedicine during COVID-19 period. She has been appreciated by IIDVL and AMC for the social work of organizing 21 blood donation drives since 1998. On an average 500 units collected every year and donated to KM Hospital, Mumbai for serving the DD patients. She has delivered various talks on dermatology issues on various national and international forums. Over to you, ma'am.
Thank you, Dr. Brijesh, for the kind words. Am I audible, Dr. Brijesh?
Yes, ma'am, very much.
Yes, thank you. So today I am going to speak on a very common symptom that we see in our day-to-day OPD, that is the fungal infection or tinea infection. So let us see how do we approach to fungal infections. So whatever we see in our day-to-day OPD is all superficial fungal infections. Not many times that we deal with the deep fungal infection. So we should know about superficial fungal infection in detail. So I thought of taking this topic up. Now, this is one of the most common forms of skin infection. Overall, 20 to 25% of people worldwide affected. And it is increasing prevalence is because of changing the virulence of the fungus, then socioeconomic conditions, lifestyle changes, migration, compliance, and irrational regimens. It is not life-threatening, but definitely it often causes considerable morbidity, and basically it always gives you the lifestyle, and the quality of life is definitely altered with this fungal infection. It affects the human hair, nails, and epidermis. It's most commonly caused by the dermatophytes. The infection is commonly designated as ringworm or tinea. The dermatophytes are molds belonging to three genera of fungi imperfecta. So one is Microsporum, second is Trichophyton, and third is Epidermophyton. Now, how do we name the fungal infection depending on the site of infection? So whenever there is a infection in the scalp, we call it as tinea capitis. Then let's come to face. Non-hairy areas of face, then we call it as tinea faciae. The beard infection is called as tinea barbae. Then the trunk, shoulders, neck infection is called as tinea corporis. The hand infection is called as tinea manum. The groin infection is called as tinea cruris. The feet nail infection is called as tinea unguium, and feet infection is called as tinea pedis, and the nails of the hand infection is called as onychomycosis. So this is the clinical presentation of tinea infection. The first picture is of tinea corporis. Then the second is tinea cruris, tinea manum, tinea pedis, tinea barbae, and tinea capitis. So what are the predisposing factors for this dermatophytosis infection? All these factors which are mentioned in this slide causes the dermatophytosis. These are the predisposing factors like poor hygiene, sharing garments, hot and humid climate, diabetes mellitus, malnutrition, pet handling, immunosuppression, common showers, occlusive footwear, and prior trauma. These all can predispose to the fungal infection. Now, let's see the pathogenesis of tinea. So there is adherence and penetration of the arthrospores or conidia into the host. There's a degradation of the keratin via the release of keratinase. It induces the first line immune response and the release of pro-inflammatory cytokines. The acute dermatophytosis is associated with a delayed type hypersensitivity response, that is CMI. And typical inflammatory symptoms such as pruritus, erythema, swelling, and burning are present. Induced scratching can increase the spread of infection and skin damage, which can lead to bacterial superinfection or secondary infection. Now, clinical picture of dermatomycosis is variable due to the degree of destruction and the inflammatory response evoked. More adapted the dermatophyte, milder the resulting inflammatory response. Anthropophilic dermatophytes cause little inflammation but can cause recurrent infections. Zoophilic or zoophilic dermatophytes tend to induce acute and highly inflammatory response. Inflammatory symptoms such as pruritus, erythema, swelling, and burning can cause a significant impact on the quality of life. Now, how do we grade the inflammation in tinea? So the first slide shows there is almost nil inflammation. In the second slide, we can see mild inflammation. In the third slide, we can see moderate inflammation. And in the fourth slide, we can see the severe inflammation where there is a redness and swelling is also present. Now, typical ringworm lesion, the dermatophytosis is characterized by the presence of ringed lesions with a healing along the concomitant presence of inflammatory symptom in the pruritic lesion. Now, if you will see this lesion, you can see there is a scaling in the lesion, there is a central clearing, and there is a increased margins. The margins are elevated, and margins are red, and it basically spreads peripherally. Now, as you can see, there is a central clearing, the ray edges are raised, Usually the lesion is annular or circular and it is sharply marginated or demarcated. Now this is the tinea corporis with secondary bacterial infection, where you can see crusting, you can see oozing, and you can see some pustules also. Inflammation is due to intense itching, release of inflammatory mediators such as histamine or prostaglandins. Thick yellow crusting suggesting the bacterial infection. Now, what are the difficult to treat dermatophytosis? Whenever there are extensive lesions, whenever there is a intense itching, profound inflammation, these are the difficult to treat dermatophytosis. Then ring within ring lesions, little or no response to antifungals, breakthrough lesions, prompt relapse after standard regimen, and poorly defined lesions, varied morphology. Now, how do we diagnose the dermatophytosis? The quality of the clinical sampling defines the performance of the mycological analysis. A sufficient amount of sample collected from the edge of the infected area by after cleaning the lesion site, collecting it in sterile glass recipient, and before the local or systemic antifungal therapy. Then transport, we have to transport it in a dry, strong black paper. And you can do the direct microscopic examination, KOH examination can be done. Most important consideration in the treatment of dermatophyte infection, including the asymptomatic dermatophyte infections such as tinea pedis, onychomycosis, are to eliminate any aggravating factor, to improve the hygiene of the skin, hair, and nails, and avoid prolonged humid environment. Topical and systemic antifungal therapy remains the central component of the management. Now, what are the treatment principles? So first, we have to analyze the site of infection, the severity of infection, mechanism of action of the antifungal agent, etiological agent, penetration ability of the drug, and distribution and retention in the stratum corneum. These all factors should be considered when we start the treatment of the dermatophytosis. Now, what are the treatment needs? So the treatment is prolonged, the duration of the treatment is prolonged. If the compliance is not good, the treatment is not going to be effective. There is a high relapse case. So we have to always, be cautious when we are treating the patient, and cost of treatment also we have to keep in mind. So why the treatment is prolonged? Because the most of the antifungals requires prolonged treatment for complete clearance of the fungal element. The non-compliance is very frequent because once the clinical features begin to subside, patient tends to stop the medicine. Why there is a high relapse? Small number of dermatophytes below the detection limit can survive in partially treated lesions and or surrounding tissue. And yes, cost of the treatment is also important. So we also need to cater that factor when we are treating the patient. What are the treatment options? First is topical antifungal monotherapy. That means only topical antifungal we will prescribe. The second is systemic or oral antifungals. And third is topical plus systemic antifungals. Now, a wide variety of topical antifungal agents belonging to different class antifungals are available for the treatment of dermatophytosis in the form of creams, ointments, gel, lotion, powder, shampoos, and other formulations. No significant differences between the numerous available topical antifungals. Topical medications have better pharmacokinetics than their systemic counterpart. It may also be used as an adjunct to the oral antifungals for more extensive infections. Now, these all are the antifungals which are available for our use. That is, in imidazole, clotrimazole is there, iconazole is there, miconazole, oxyconazole, sertaconazole, liliconazole, iberconazole, then efinaconazole, then allylamines, terbinafine, naftifine. These we don't use it very frequently. In others, amrolfine. Amphotericin also reserved for the systemic fungal infection, deep fungal infection. The addition of corticosteroid to an antifungal agent at the initiation of treatment can attenuate the inflammatory symptoms of the infection and increase the patient compliance, reduce the risk of bacterial superinfection, and enhance the efficacy of the antifungal agent. Incorrect use of antifungal corticosteroid therapy may be associated with the treatment failure and the adverse effects. Systemic antifungals are indicated in case of extensive involvement and the patient failed topical therapy. Griseofulvin, terbinafine, fluconazole, itraconazole are currently recommended systemic antifungal agent for the treatment of dermatophytosis. Treatment duration varies as per the type of tinea, severity, and as per the drug. but generally it is 2 to 4 weeks. But nowadays we may have to give it to 4 to 8 weeks also because of tinea incognito, steroid induced or steroid modified tinea. Systemic therapy is indicated in following: tinea capitis, tinea affecting the nails, tinea involving more than one body region, tinea corporis, where lesions are particularly extensive, tinea pedis, where the extensive involvement of the sole, heel, dorsum of foot, and whenever there is a recurring or troublesome restraint. Now, recommended dosing of the different systemic antifungals in dermatophytosis. In tinea corporis and cruris, terbinafine 250 milligram once daily for 2 to 3 weeks. Itraconazole 200 milligram per day in divided doses for 1 to 2 weeks. Fluconazole 150 milligram to 300 milligram per week in 3 to 4 weeks. Griseofulvin 500 milligram per day for 2 to 4 weeks. Terbinafine in tinea pedis, again terbinafine 250 milligram once a day. Then itraconazole 100 to 200 milligram. Fluconazole 150 milligram per week, and griseofulvin 750 to 1000 milligram per week. In pedis and in onychomycosis and in unguium, we need to give the treatment for a longer period. So chronic and recurrent dermatophyte infections, when do we basically give topical plus systemic antifungal treatment? Whenever there is a chronic and recurrent dermatophyte infection, combination is expected to have a better mycological clearance than systemic or topical alone. Combination should be from the different groups for a wide coverage and also for the emergence of resistance. And combination of both can reduce the duration of the treatment, prevent the emergence of the resistance. Now, this is the treatment grid for the spectrum. If it is the mild infection, only give topical antimicrobe, topical antifungal. Then, if there is a moderate duration, then maybe you can give combination therapy. And whenever there is a severe fungal infection, you can give the systemic plus topical antifungal. Now, how we should instruct the patient? Ask them, if you discontinue the medicine in between, it may again lead for the reinfection. Tell them to iron the undergarments and clothes from inside out to prevent the infection. Keep the infected area as dry as possible to prevent the infection. Cream should be applied on and around 2 centimeters around the infection for better results. Treat your partner also, as fungal infections are contagious. Talk to the family members. Don't share towels, napkins, and it may spread the infection. So the reassurance and the health education is very, very important. Patient education plays a very important role. So if you happen to see the patient with the nail infection, then you tell them, cut your nails regularly, avoid scratching. Itching can get worsen if scratched with grown nails. Complete the treatment as recommended by doctors. Do not stop the treatment even if you get relief from itching, because fungus can come back if not killed completely. If the patient has got fungal infection and clothes, what should we tell them about the clothes? Wash and iron your clothes regularly. Wash and iron your undergarments regularly. When you iron the clothes and undergarments, the left out fungus gets killed, as the ideal temperature to kill the fungus is 60 degrees. Avoid wearing tight clothes. Sweat and dampness create ideal environment for the growth of the fungus. Never share the clothes with anyone, and fungus can pass from one person to other. Complete the treatment as recommended by the doctor. Don't stop the treatment even if you get relief. Then patient should wash their feet, especially the web spaces area between toes, daily. They should dry the feet, especially web spaces, after bathing. Change the socks daily. Alternate between different shoes every 2 to 3 days, and wear plastic sandals in the changing room. Feel free to consult your doctor if any of your family members have fungal infection. Remember, do not self-medicate. Then, summarizing, accurate clinical diagnosis of superficial fungal infection is a key step in the successful treatment. However, timely treatment is also important, as dermatophyte infection is communicable. Treatment approaches include both topical and oral antifungal agents as a combination. Prolonged treatment duration and poor compliance as the patient discontinued treatment once they experience clinical improvement are the biggest challenges in the management of cutaneous mycosis. The most effective way to combat the superficial fungal infection may be basically tell the patients on the preventive measures to be undertaken in conjunction with the treatment. Additionally, maintaining personal hygiene, Wearing loose fitting clothing and keeping skin clean and dry may improve the treatment outcomes. Now let's, this is a quick topical steroid abuse I would like to, emphasize, because it's very important, because we tend to see lot of tinea incognito patients, because patients do buy steroid formulations from the over the counter from the pharmacy, and they keep on using, and then we are in the trouble how to treat the patient, because the treatment becomes, the fungal infection becomes very resistant. So let us see some infections. So this is how the fungal infection looks. See, these all are the steroid abuse fungal infections which I'm trying to show you. You can see this. This is the tinea faciae. This is a child who has got the tinea around the eye. You can see the extensive striae, basically because, and thinning of the skin, telangiectasia, everything is seen in this slide. These are also extensive striae, telangiectasia. So side effects of the steroid creams on the face can be increase in the people's. Also, the patients tend to use a steroid cream for the fairness, and they'll end up in tinea incognito. There can be an increase in the pimples. That is the side effect of the steroid creams. Atrophy of the skin, telangiectasia, hirsutism, perioral dermatitis, and or rosacea, fixed redness of face. Finally, a topical steroid dependence develops in the user. So we have to always avoid. So you can see the rash on the face, steroid-induced acne you can see. This is the grade 1 acne. This is the grade 2 acne, grade 3 acne, nodulocystic acne, severe acne. Then you can see the thinning of the skin. Here you can see the striae as we have seen earlier. You can see the rosacea or the permanent redness of the face. You can see the acneiform eruption on the chest and back and neck because of steroid. This is again the steroid acne. You can see this acne on the face. Here also nodulocystic and severe acne. This patient has used steroid for the melasma, and you can see she has landed up in severe acne. This is hirsutism. You can see the excessive hair growth on the face. Here you can, basically see it well. This is the excessive hair growth post steroid. You can see this. This is perioral dermatitis. This is also perioral dermatitis. You can see because of excessive use of steroid. You can see the thinness of the skin, purpuric patches, telangiectasia, thinning of the skin. These all are the triple combinations which are commonly used by the patients, which gives rise to these kind of steroid acne. So we have to always avoid. You can see in this child, you can see the thinning and stretch marks over the body. You can see how severe they are. These are the potency. There are very high potent to mid potent steroid. We must know the classification before we use them, because maybe not all steroids can be used on the face and intertriginous area. So avoid potent steroids on infants, eyelids, axillae, groins, and extensive body surface. Use low to mid potency steroids for acute and subacute eczema. Use potent steroids for chronic lichenified eczema, palmoplantar psoriasis, hypertrophic lichen planus. No steroid cream for ringworm. Use plain antifungal cream like clotrimazole, miconazole, laliconazole, cetaconazole, ibuproconazole, bifenazole, amrolfine, and terminafine. See how the dermatophyte looks. You can see all these pictures are showing that this is the classical dermatophyte or tinea infection. These are the low potency steroids, that is clobetasol, butyrate, hydrocortisone acetate. These are the mid potency, mometasone, fluticasone, betamethasone, valerate, and fluocinolone acetonide, 0.025%. These are the high potency steroids, clobetasol propionate, betamethasone dipropionate, halobetasol propionate. Many combination steroid creams contain clobetasol, so do not use them. Such combinations are irrational. So this is the IADVL's task force against topical steroid abuse. So basically, all these steroids, mometasone especially, which is used very commonly, is the pregnancy category C. Betamethasone is pregnancy category C. So please, when we have to use it, you have to use it with very lot of caution. Hydrocortisone is category C. And these all are schedule H drugs also. So you have to, clobetasol and all, we have to use it very cautiously. Fluticasone, mometasone. So we have to basically avoid the drug abuse, and we have to very cautiously use the steroids. And for fungal infection, use only a topical antifungal, and if required, as I've told the conditions, then only use the systemic antifungal. Thank you so much for this opportunity given to me. Thanks a lot. Over to you, Dr. Brijesh.
Hello.
Yeah.
Yeah, thank you, Dr. Ratnaprabha Pisar-Posa. That was really an enlightening speech. There are few questions regarding the lecture. I'll just go through it. Would a fungal infection of epidermis get converted to fungal infection in uterus during pregnancy? Will it start from outside to inside or from inside itself?
No, no, no. This will not go to uterus for sure. This is superficial. It will remain in the epidermis. So whatever we are trying to do is we are trying to extract the fungus out of the epidermis. This is not going to go deeper.
Okay. How to manage resistant Pinia carpori not responding to 4 weeks topical therapy?
So when it is not responding to the topical therapy, first of all, we have to find out what are the predisposing factors. You investigate the patient, whether the patient is having diabetes or any immunocompromised condition. And then anemia is also commonly, seen in this resistant patient. So basically analyze the patient and then start them on a systemic antifungal, do the scraping and see what kind of fungus it is, do the Woods lamp examination, because that also can show you how to, diagnose. And then accordingly, maybe you can start with terbinafine orally or itraconazole orally, and you can treat them along with topical. So systemic as well as topical should be combined in this resistant case, and you may have to give all the whatever I have personal care. I have told them that keep the towel separate, keep the soap separate, iron the clothes inside out, cut the nails short, so that prevalence recurrence is prevented. Yes.
Okay. Combination of 2 orals.
Yes. I did not understand the question. Do we combine 2 oral? Do they want to
There's
ask?
one question. Combination of 2 orals means might be can we use 2 orals at a time or that all?
We can definitely use 2 orals without any doubt. But only thing is you give a sufficient clinical trial of one agent. Okay, at least give it for 4 to 6 weeks. And if it doesn't respond, then maybe you can add the antifungal of a different category, not the same category you add. Maybe if you are using itraconazole, try and add terbinafine or try and add griseofulvin. Again, do not add something. Even in, I have mentioned it very clearly, when you are giving 2 antifungals, topical as well as systemic, give 2 different categories. Like, if you are giving itraconazole, at least try some other this thing. Try the terbinafine topical or try ketoconazole topical. Something like that. You use the different categories. If you will ask me, as a dermatologist, I don't need to combine 2 antifungals. Up till now, I have not come across that I had to use. If you give antifungal in a proper dosage, if you reassure the patient, if you give health education to the patient and wait for the sufficient time, it does clear. I don't combine. I have not combined. There is no need to combine if you have given it in a proper dosage and if you have analyzed and examined the patient well and seen all the predisposing factors. Because see, suppose the patient has got uncontrolled diabetes, whatever antifungal you will change or combine is not going to respond. First control is diabetes. So what I want to say is just see the predisposing factor and go accordingly.
Okay. Thank you so much, ma'am.
There is one more question. Which antifungal treatment for CKD or single kidney patient for onychomycosis?
See, whenever the patient is on polypharmacy, terbinafine is always safe. But just see, like, first of all, when we are seeing this renal disease patient, we have to basically monitor everything, that his profile, and you have to see how severe is the renal impact, because onychomycosis is not going to be life threatening, but the kidney disease is. So you have to always weigh the, whether you really need to put the patient or you can do without it. Because if the patient is on dialysis, if the patient has got severe kidney impact, then onychomycosis doesn't really become very important, so that you give him one more troublesome drug and increases. But for all polypharmacy patient, you should consider terbinafine.
Thank you. Over to Dr. Mahesh Saunke for vote of thanks.
Dr. Madhuri, I can see one more question. Can I take it?
Yes,
Yes,
madam.
ma'am.
This is by Dr. Kavita. As in my clinic, most of the
Before that, madam, she has written, according to you, which is the first line of drug on the patient who already use systemic cream having steroids from OTC? As in my clinic, most of the fungal infection patient comes already with pre-treatment with OTC or from other doctor, but with relapse. Then what will be your approach for this patient for the treatment?
Yeah. First of all, stop the steroid. First of all, let the patient be come out of the steroid, and then maybe you can give itraconazole, you can give terbinafine, depending on, you have to analyze the patient, or you can give all the antifungals are effective. Only thing is your selection should be right. So any antifungal you can start on, and if at all you are starting on griseofulvin, maybe give laliconazole or sertaconazole. So give different types of antifungal, and I think again, what is the site of infection, whether it is tinea capitis, whether it is tinea fasciae, whether it is unguium. So depending on that, also the choice of drug is important. So depending on that you can choose, but itraconazole you can give if the patient is not comorbid, if the patient is not on polypharmacy, itraconazole works well. Maybe you can even think of giving the pulse therapy. Even pulse therapy works. So it depends, like it varies from patient to patient, from the clinical infection, how the clinical picture is. Accordingly, maybe it's, but you can decide. But the terbinafine and griseofulvin had most side effects. It again depends. It's not see, even ibuprofen has got a side effect. Even Septron has got side effect. But you have to use it cautiously. Not every patient is going to show. Maybe give them the dose first. Just see, ask them whether there is any history of drug. Do they have drug reaction earlier? Do they give any history of the drug reaction? And then you can safely start. Maybe start with half dose first. Maybe on few days you give a half dose, and then once the patient is developed, you are sure that patient is not allergic to that drug, you go ahead and start on the full dose, full drug. There's not much problem with these molecules. Also, we use griseofulvin. Only thing is, yes, you have to monitor LFT without any doubt. Monitor LFT, monitor RFT, and then go ahead, see the hemoglobin level, see everything, and then go cautiously. It's not that we don't tell you to go blindly and start the drug, but do investigate, because this infection is going to take a long treatment, long-term treatment. So do investigate before you really go ahead with the treatment. What is the role of the soap like KZ in the treatment of tinea? No role, no role of any soap, because it's not, how much contact period does the soap has with your infection? Not even few seconds. So it doesn't have any role. So there's no need actually to give. No need to give.
In children, there's one question.
This question from Gareth. Combination of two orals, that same continue in children.
No, I see, as I said, even in adults I have not given two antifungals. Only thing is choose a right antifungal, and one, if your diagnosis is correct, if your culture is telling you with what the patient is sensitive for, you can go ahead with you do the culture sensitivity if all you want. If, instead of, when you are adding on, you keep a backup. Why are you adding? Just don't add for the adding sake.
Last question, role of antiperspirant.
See, what we suggest is, we ask the patient to take the bath twice or thrice a day, because antiperspirant, if the patient is really sweating profusely, in the intertriginous area, he or she may, apply. But then we really do not suggest it is, I don't think it is necessary or it works. I don't think that there is any rule per se. But ask them the patient, ask the patient to wear the cotton clothes. If the patient is wearing synthetic clothes, it's going to sweat more. If the patient is going to the tight clothes, is going to sweat more. So basically, advise the patient on loose and cotton clothes. Then take the bath twice, dry the area well, and remain in the cool environment if possible, under the fan. Or I mean, we cannot advise AC in our this thing, but just try to be in the comfortable environment. You can always advise the patient. No role of antiperspirant per se, as far as the scientific this thing goes.
Thank you, madam.
No role of
We
powder
take
also.
last question. There is one more question that will be the last actually. In recalcitrant dermatophytosis, dosage of systemic antifungal should be increased or not?
No, no need. It doesn't work. Even if the patient is obese 150 kgs, doses remain the same. No need to increase the dose. It doesn't work.
Okay. Go to Dr. Madhvi.
Yeah, thank you, Kosa ma'am. Over to Dr. Mahesh now, okay, for vote of thanks. Dr. Mahesh, you're there?
Thank you, ma'am. Am I audible?
Yes.
Yes, sir. Yes, sir.
This CME, annual CME is arranged by Bhinder Medical Association in association with IMA Mira Bhinder branch. So I would first like to thank BMA and IMA for arranging this. I hereby want to specially thank our speakers, Dr. Suraj Chirania, Dr. Navneet Madam, Dr. Sandeep Patil, for excellent triple combination anti-hypertensive, enlightening our knowledge. I thank Dr. Mithilesh Mishra also for our improving our knowledge on varicose veins treatment. Dr. Ashok Shukla, I did said that in my medical college, our forensic sir used to say, if you are poor in clinical knowledge, you will harm the patient. But if you are poor in medical legal knowledge, you will harm yourself. So medical knowledge, medical legal, thank you, Dr. Ashok, for telling us in depth how to deal, how to record, keeping about IPD and everything in detail. I want to thank here President Team BMA under Dr. Leadership of Dr. Ratnaprabha Posa, IMA Dr. Vivek Dwivedi sir and team, and whole team who have supported directly, indirectly. Thank you DigiShield for providing us technical support, and special thanks to Dr. Amol, who was too busy and who, along with the team member, who made this virtual session so lively. So, one and all, thank you very much. And I hereby declare that session is concluded. Thank you, sir.
Thank you, everyone. Thank you, Piyush.
Yes, sir.
Yep, thank you.
Shall we leave, Dr. Amol?
Yes, we can leave. Thank you. Thank you,
everyone.
Yeah, thank you.
Yeah, thank you.